Thank you.
Members, please pull the microphones towards them when they're speaking. Thank you.
Great.
Yeah, thank you, Chair. I'm declaring an interest. I'm a Rotary Evans. I'm the local authority councillor on the board. And on item 3.6, Kilgaren model, and also 3.8. 3.8 is just some kind of interest, and 3.6 and specific reasons.
Great. Diolch, Rodri.
So, diolch, Chair. So, Councillor Evans, as members will be aware, is the Health Board's local authority member on the board, and as Rodri's just done, has declared an interest in item 3.6. This item has been discussed in detail, and although Rodri is not representing Ceredigion local authority, he's on the board to bring the local authority perspective on matters. Due to the involvement of the Ceredigion Council in the Kilgaren project, we've agreed, and also Councillor Evans' ward being directly next to Kilgaren, we felt that this is a personal and professional conflict of interest, Chair, and therefore Councillor Evans will withdraw from this discussion.
Great, okay. Diolch, Rodri. Thank you, Chantal. Great, okay. Let's turn to preliminary matters. So, can we first of all confirm the minutes of the public meeting held on the 11th of July 2024? Are members happy to approve those minutes? Any amendments? No? Great, let's confirm those minutes as agreed. And then the minutes of the public board meeting held on the 25th of July. Are members happy to agree those minutes? Great, thank you very much. And then if we could turn to matters arising and table of actions. This is for assurance, to assure ourselves that all actions have been taken.
Yes, Chair, and as you can see, there's an update against each of those actions, which we can now close, unless members have got any specific questions on those or require any further detailed updates.
Colleagues, any questions or concerns about those actions? No? Great, okay, let's agree those actions and confirm our assurance. Great, let's move to item 2.4, which is the report of the Chair. You'd have all had details of my pattern of activity over the last since the last board meeting. Colleagues, any questions or anything you would like to add? Any points of clarification? You'll note on the first page under assessment that it refers to my first meeting with the Cabinet Secretary, which took place yesterday. I think in the papers it's with Mark Drake with MS. It was actually with Jeremy Miles, and that took place yesterday. Yes.
Just one thing I would like to highlight is the really sad passing of Dr. George Elton that's outlined in your paper, Chair. To me, he was a friend and colleague. He was an absolutely superb doctor, well loved at Glangwili Hospital, held, was a big part of our medical registrar rota for many years, and also was the life and soul of the SDEC, the same day emergency care department at Glangwili. So we will really miss him. We already really miss him. And I know colleagues will be feeling his loss greatly. Thank you.
Thank you, Phil. The only other points I would raise is that since my last meeting, I feel I've engaged more with the service. So kind of leaving Ystwyth and visiting different parts of the service. I visited the Cancer Centre and neonatal services at Singleton, which we are largely responsible for co-funding and delivering our service through there. And I also visited Glangwili, which Irie Edmonds kind of gratefully accompanied Phil and I around. My observation, I left feeling humbled, frankly, because I think there's an awful lot of, most of the time we find ways to critique or to worry about the services we provide. And indeed, there was lots of things that caused me concern. in my visit. But one of the things I did not feel concerned about was the quality and the confidence of clinicians and the services they were delivering inside those spaces. It was humbling to see that, often under quite challenging circumstances. So thank you, Irie, for that opportunity, and I intend to do more in the future with Bush in the next week or so, and then Bronglais following that. And I'm very happy to visit other sites as and when the opportunity occurs. Thank you. If there's no other points relating to my report, then I'm going to move us on to the report of the Chief Executive.
Sorry, Chair, before I move on, just can we take members to the recommendation, because we have undertaken Chair's action twice on behalf of the Board, so I just need the Board to ratify those actions, and the details are within your paper.
Members, are you happy to ratify the actions that I took during that period?
Yeah.
Great, thank you very much.
Thank you, Chair.
Great, thank you for reminding me. Great, on that basis then let's move to the report of the Chief Executive.
Thank you, Chair. So this report gives details of activity since the last board. I'll take the paper as read. There's one item I did just want to particularly draw attention to, which is the update on St David's surgery. Since our decision last board meeting to progress with managed dispersal, we have had a large amount of correspondence from the public. We do recognise the concerns of the local community in St David's, and we are, as you can see from the paper, progressing work as rapidly as we can to make sure that we do have general practice cover for that population. I think what I'd like to do is also hand over to Jill Patterson, our Director responsible for primary care, to give us more detail perhaps on those actions, given the amount of public interest in that decision.
Yes, thank you very much, Chair and Chief Executive. This is a really important item for us, and actually I'd just like to thank everybody first for their patience as we work through this quite challenging period, quite a short space of time, to be able to ensure that we do have services in place that are safe and sustainable from the 1st of November. We do recognise, however, that there has been that large amount of correspondence, particularly from individuals who live very close to the existing St David's practice, and we recognise those concerns. And as well as giving an update on some of the practical issues which are very positive, I thought I would highlight some of the issues that have been raised in the correspondence, and particularly we'll pick up the letter that was submitted this week from the St David's City Council. Now, all of the letters that have come in recent weeks do continue with the same theme, so I will highlight those. But I'd like to start off with some positive information, and certainly that's the name of the practice. We agreed that at the last board meeting that we would ask the working group to come up with a name that they felt would provide that sense of a new start. It would move away from Solva and St David's and signal the start of that new practice. And the name that the working group have come up with is the Peninsula Practice Meddygfa Penrhyn. So there will be signage going up at the start of the opening of that practice, and that does signal that new start. In terms of the premises, and we know that there's been quite a lot of concern around the work that is due to be undertaken in Solva, and people are saying, well, nothing's started yet. And it's very hard for a community to have belief in the decisions that we've made when that work isn't evident. Now, what I hope people will appreciate is that there are legal processes to be undertaken in terms of agreeing to undertake those works with the landowner. The landowner's been out of the country for some time, but is back, and I know is meeting with solicitors today. So we hope that once that is finally signed, the building work will start. The plans are all in place, and we have a contractor ready to start. And just in terms of the space, again, the council and others have raised the fact that the Solva building is small. It is larger than St David's, and we have some underutilised space on the premises. We'll be moving some administrative space up to the upper floor, and we also have a dispensary which was closed in 2023, so that will be converted into additional consulting rooms. We also know there's concern around parking and the fact that individuals will have to travel to Solva. So in terms of parking, there are 18 parking spaces at the Solva building. There are none currently actually at St David's, so and no staff will be able to park in those places. They will have allocated spaces that we've been able to contract outside of the surgery premises. And in terms of travel, we recognise that that is a challenge. Some individuals are going to have to travel 3 miles to the Solva surgery, but we hope that that need will not be significant because we are working to provide as many services in the local community as we can, and I will come on to that. But in terms of travel, we've been working with PACTO, the Pembrokeshire Association of Community Transport Organisations. We have a leaflet that they have helped to develop, and they are looking at some flexible arrangements, looking for now drivers to assist with that process so that they can respond to need where buses are not available for individuals. But we've also had a commitment from the surgery that they will work as far as possible that when people do need to go to the practice, that they will try to accommodate appointment times with bus times. Now, in terms of the local premises, we also signalled that in response to the concerns raised through our equality needs impact assessment, we identified that difficulty of travel for some individuals, particularly who are older, perhaps at a disability, and the need to respond to some local arrangement. So the board did agree to a branch surgery. And again, we've had questions raised as to why have people not heard yet about the arrangements for that branch surgery. Again, that has been due to sensitive legal conversations being undertaken with some premises that we had identified, but just to assure you that in terms of coming to that particular premises, we did undertake a lot of scoping of available facilities in the area with the local authority and with community individuals to identify a suitable set of premises. And I'm really pleased to confirm that the owners of the premises have agreed that we can announce today in public the building that is going to be used for those branch facilities. It's not confirmed and signed yet, but they don't see any impediment, so they are pleased that we put that name in the public domain. I'm happy to confirm that the branch surgery will be in the Shalom building in St David's. So we will have 2 rooms there, which we will be utilising. Our staff are going in now to look at the services that we can plan there. And those services will largely be provided by the multi-professional team. So things such as nurse-led chronic disease management clinics will run daily, things like phlebotomy, and we'll be having some community services there and some cluster-based services. We're also working with a local pharmacist. So again, patients may have been used to having to go to the surgery to request a prescription, then go back to collect the prescription, and then go to their community pharmacist. So you will not have to travel to Solva to request your prescription and collect it. We will be working with the local pharmacist, hopefully to allow you to drop your request off into that pharmacy, and we will arrange for the medicine to go straight to that pharmacy without you having to go to Solva to pick that up. So again, we're trying to do as much as we can to ensure that footfall to the Solva building or to the Medigfa Penryn building is as limited as possible and should really only be needed when you need that medical appointment. Now, one of the other issues that the council and others did raise is that they weren't sure that we would have sufficient medical staff or clinical staff to be able to cover the needs of the enhanced population size. So there are going to be 3 permanent GPs in the service, as well as a range of locums who have continued to provide service to the existing Solva premises. Subject to pay transfer and those conversations that are going on with staff, we will have double the complement of a nursing team. We'll have both nursing teams, and we will have the administrative team from both practices. And they are working really closely together. And I'd like to thank the staff actually for the way in which they've embraced this and are working together to be able to provide that seamless service for patients in the future. So again, patients will see many of the faces with which they're familiar through this transition period. Now, what we have committed to do is to continue to keep that service under review. So we will undertake a formal review in 6 months, but also you will have practice managers there that should you have any concerns during this process, you should be able to raise those concerns. The council and again other letters suggested that this had been a rushed process and perhaps we'd made decisions as a board based on inadequate information or misinformation, particularly in terms of financial costings, etc. And I'd really like to assure the board and refer board members back and members of the public back to the very comprehensive set of papers that were provided. We did undertake that formal engagement period in conjunction with a plan which we devised with LICE, which ran from the 13th of May to the 19th of June. And in addition, we had multiple means of the opportunity for individuals to provide their views to us. So again, I would want to assure members of the public and the practice population that this was a decision that was undertaken based on evidence in order to provide that service of quality and safety for patients going forward. The other question we've been asked by members of the public is this deadline real? Can't we just hold it off? And I'm afraid we can't. I think I did make the point during the presentation previously that when we do receive a termination of a contract, we contractually have only 6 months to respond from the day in which that notice is provided to the health board. We have to assure patients of a service that is sustainable and safe from the 1st of November. And actually, in listening to patients, we provided that additional service of a branch surgery, which we've now committed to, which I've been able to confirm today. So I do hope that listening to this update and you have further information in the Chief Executive's report and also to confirm you will all patients registered will be getting a 4th letter this week or next week, which will be your welcome letter. Patients have already had 3 letters. Their 3rd letter confirmed the practice to which they were allocated. We've undertaken a small number of changes since that time where patients have raised concerns. But the 4th letter will remind you of the practice to which you've been allocated, and it will include a welcome letter from the practice to which you've been allocated with some information about that practice, and it will also enclose the Pacto leaflet around community transport. So I'd like to thank everybody for the way in which they're supporting this. We have to get behind the staff. We have the deadline of the 1st of November coming up, and people are working very hard to ensure that services are going to be ready for you from the 1st of November. And the opportunity is still there to talk to and engage with our community. Our community are engaging through the Peninsula Working Group, and as part of that future modelling, they've been asking questions around what matters to the community and how can the community itself become resilient and sustainable and work with us to design that integrated future. Thank you.
Thank you. Can I just ask a question, Jill?
Yes, please.
So the location of the Shalom branch surgery, I'm presuming that is accessible?
That is accessible, and it is in St David's.
Very good. Okay. Chantal.
I was just wondering around the continued monitoring and evaluation of how, given the concerns that have been raised, as to what are those measures that are you going to put into place in order to continuously monitor the situation?
Where we have undertaken these before, and actually where we have managed practices, our staff, to be honest, are in there pretty much daily and weekly. And actually, we have very regular input from all of the practices that we manage directly. And I take that responsibility very seriously because it means that the health board is actually responsible for all of the services that we're providing within that facility. So we'll be undertaking a number of issues, particularly around concerns that may be raised by patients to either the health board team or to the practice team. We will be working with LICE in terms of any issues that are raised through that process. We'll be undertaking the audit of some of our clinical records in which we have to look at the monitoring of that service. And we will also engage with the population formally at the end of that 6-month period, again, to undertake that review. But we are working with the clinical team as well, who have a responsibility to undertake certain quality programmes and clinical audits themselves. So we'll be looking at that as well, Chantal.
Thank you, Jill. Thank you.
Thank you. 2 other individuals, and then I want to move us on. Michael.
Yes, thank you, Chair. I mean, just on the last point, we have a duty to continuously kind of engage with people. So that 6-month review is going to be an opportunity to see pick up any issues or anything else. My question really was a communication question, because I can remember this coming up at the meeting in Aberyron 2 months ago, and we are faced with a closure. That is something which is not in the hands of the board. It's GPs retiring, etc. And there's no criticism of that. That's what happens. So we have a closure, and I can remember a very productive discussion, constructive discussion we had, and that was about the branch surgery. And so when I came away from that meeting, I thought, well, that was constructive. The idea of the branch surgery being in St David's. And then when I got home, I turned on Wales Today, and the headline was, Health Board closes everything and abandons St David's. I just thought, no, I'm sure that didn't happen. And so I just wonder, so here we commend Jill for what her report just now and all the activity that's been. It seems to me that's an example of trying to think outside box, trying to listen to communities, and yet that message didn't seem to get any traction. So I just wonder about that kind of the communications in that respect. Thank you.
I'm not convinced there's an answer to that, but I will offer Alwena the opportunity to come back on that before I go to Ewan.
Thank you, Chair, and thank you for the question. Yes, I think in our communications that have been out there, we have been calling out the availability of the branch surgery in St David's, and we have reiterated that through all our communication. However, what we put out there isn't necessarily what's reported every time, unless we were to invest in buying advertising, which I'm not suggesting we do. However, now that we are able to share the location of where the branch surgery will be, we will send out a further update about it this week, so that we will continue to work with our local community. And just to reconfirm that much of the communication has been direct to the patients impacted through those letters that Jill mentioned.
Diolch. Ewan.
Diolch, Cadeirydd. Thank you, Chair. I think firstly, thank you to Jill for the confirmation of this update today, which I think the community was clamouring for this confirmation in terms of what's happening with the branch surgery and with the buildings, and appreciate the work which has gone into this. I think it's also important that we do reflect and remember the staff involved, and they've been at the kind of centre of this cataclysm in terms of debate. And I think again, the support that we have for the staff in both kind of St David's and Solva is key. But I think in terms of the timings, and I think the community, certainly from conversations I've had being based in Pembrokeshire in the third sector in this, is that the timings are still of concern to the community in terms of whilst they are, I would hope they are now happy with the confirmation we've received today in terms of the buildings, there is still only a 6-week window in terms of when we get to the 1st of November. So will any remedial works, construction works, reconfiguration aim to be completed by the 1st of November so patients can have a seamless service, staff can feel as if they're moving forward, or will there be a period of kind of coalescence in terms of construction and in terms of delivery within the new structures that we're seeing in the branch and in Solva?
Question there. Yep.
Thank you. And I think, as I indicated in that earlier update, unfortunately the building works in Solva have been slightly delayed due to some of that legal process. So the welcome letter that goes out to those who are transferring into Solva does indicate that there's likely to be some ongoing building works during that first phase of opening, although subject to, hopefully, a fairly soon sign-off on the lease. We will have 6 weeks or near enough to be able to do as much as we can prior to that date. So we will be working with patients and asking them to work with us as well around that. But we apologise in advance, should that be the case, that there are still building works that will be going on at that time. In terms of Shalom, our teams are now going into the Shalom building and working with the trustees there to look at any things that needs to be done in terms of making those facilities ready. So that work is also ongoing. Thank you.
Thank you very much. To bring this matter to a close, this has not been an easy decision. This has been a challenging one because we know that it's not pleased lots of people living in the city of St David's who are concerned, and quite rightly, about what the future will hold in terms of their treatment. It's a decision that I think is well-founded and evidence-based, and you're right, Michael, the conversation was rich and detailed when we last discussed that. But I don't think we should close ourselves to the fact that that doesn't always satisfy the public, and their concerns can still continue. So I think we have to work hard to stay connected with this community and find ways in which we can offer them the reassurance that that we are committed and genuine in our desire to want to maintain a service that best meets their needs. This is just the approach that we've chosen at the current time.
And I confirm that that is a genuine desire from ourselves to work with the community, and we have that Peninsula Working Group which has those community representatives on it, but I'm also open to other suggestions that the community may bring forward as to how we can do that differently.
Thank you, Jill, and thank you for your hard work on this. I appreciate how much you've done to take us to this current position. Great. Phil, I'm going to hand back to you.
Thank you. So, Chair, I will take, as I said, the paper is read. There are some matters to be endorsed and approved, but I'm happy to take any questions on the rest of the paper.
Yeah, thank you. Just right at the end of the paper, regarding the reinforced concrete rack, I see the work's going to be starting in December ground wise. It's good to see there's no impact in service, but how long will that work take?
Might want to bring in Andrew Carruthers on that.
Thank you. I believe it will take somewhere between 3 and 6 months to complete all of the work.
Thank you. Anna, and then Maynard.
Thanks, Chair. Phil, page 2, bottom of page 2, you refer to the strategic outline case and programme business case, which of course has our hospital reprovision at the heart of it. I wonder if you could just expand a little on the meaning of what you've included there, including reference to exploring additional scenarios. I wonder if you could just make that a bit more transparent for the public, please.
Yeah, thank you. And I'll probably bring in Lee in a minute, but we agreed our strategy back in 2018, so 6 years have gone by, and of course COVID intervened. I think that inevitably affected some progress, but I think like us, well, Welsh Government and us, I think, would say that we do need to reflect on the learning from those 6 years and any learning from COVID. So I think it is going to be important that we do at least assess our strategy to see whether there is any different learning that we can apply to it. And I think it would be important to refresh it as we move into next year. I think the basic tenets, from my perspective, of the strategy and the basic principles are really sound. But it is important that we learn, I think, from the last 6 years. In terms of the discussions with Welsh Government, one of the really key points that they've been indicating to us is that when a business case is considered, there needs to be a range of options put forward as part of that business case. So whilst we haven't agreed with them what those options would be, there have been discussions about broadening the options to make sure the business case process is as sound as possible, because we can't just present one option. So I don't know, Lee, whether there's anything you would want to add to that.
I think you've covered it largely, Phil. Just to remind ourselves that the programme business case was submitted in February 22, so on the business case process. That is the last document that we've agreed as a board and submitted. That remains unendorsed by Welsh Government, so we were asked to produce a strategic outline case, and the Nuffield Trust were commissioned to review our clinical services, which obviously we brought through board as well. So the key consideration for us, as Phil's indicated, is that Welsh Government have formally asked us to consider the widest possible set of options that we could include within that strategic outline case, which broadens the options that we would have in the SOC that we've been drafting and goes beyond what we set out in the programme business case. But we're working through with Welsh Government now exactly what is meant by that and what those options could include. And then we're going to need to consider as a board what that means for us, both in terms of the strategy conversation that Phil is describing, but also the timeline, as the paper indicates. There is obviously a delay now on the original timeline in the programme business case.
Thank you.
Thank you. Maynard.
Question's been asked.
Your question's been answered. Just in my view, the strategy is 6 years old this year. Most strategies operate over a 5-year period. So it is time for us to bring a kind of refresh perspective to the strategy, remind ourselves why that strategy is there and what we're trying to achieve as part of that process. So I think it's a kind of MOT around our strategy to make sure that it is still absolutely what we wanted to do. It was a pre-COVID strategy, and the world is a different place since that time. So realigning it is not problematic in my view. It's a good thing. It's a healthy thing to do as an organisation. Very good. Okay.
Good. So, if there weren't any other questions, the only particular area that's for approval is the work around the Joint Commissioning Committee,
Yep.
which I am part of. I represent the board at that committee, and all those papers have been scrutinised at that Joint Commissioning Committee, but do need to be approved at every board.
So shall we just run through those approvals before we move forward? So we're first of all asked to endorse the Register of Ceilings, which is in Appendix 1 of the papers, since the previous report on the 25th of July. Members, are you happy to endorse the Register of Ceilings? Thank you. Note the status of the consultation documents, Appendix B. Approve the following documentation which forms part of the JCC, the Joint Commissioning Committee Governance Framework. The Memorandum of Agreement, the Hosting Agreement, the proposed subcommittee structure. I'm presuming from your acquiescence you're not massively anxious about the state of this documentation. The continuation of the transitional reporting arrangements for all Wales individual patient funding requests. Great, okay. Fine. Thank you very much. And then just to note the terms of reference for the Cwmtaf University Health Board in terms of their management and the kind of audit governance architecture that will sit around the committee. Everybody's comfortable with that. Great, thank you very much. Thank you. Happy to move on?
Happy to move on.
Great, okay. So I want to move us on to the next section of papers in our board. This is delivering on our purpose, quality, safety and performance. And I'm going to invite Hugh to take us through the financial report.
Diolch, Cadeirydd. Yes, I won't take us slavishly through each paper, but I will just highlight some of the headlines on the finance position. We know that the plan that we set out to deliver a deficit of 64 million this year is not an acceptable plan to Welsh Government, and I know not an acceptable plan to the board. But in relation to achieving against that plan, it's been a positive month. And I want to thank colleagues across the Health Board, because I know that progress to get to this point hasn't been easy and has been hard fought and hard won. So the position in month is a deficit of 5.4 million against the plan equivalent of 5.3 million. So a 0.1 million adrift from that. And largely that's been down to improvements in our use of agency staff across the Health Board, and specifically nursing agency, which has demonstrated a significant improvement, and the delivery of savings as well. We've seen an improvement there as well. But one swallow doesn't a summer make. I'm very conscious of that, and we need to see what the trend continues like for the next few months now to gain greater assurance over that. But we have made progress in reducing the savings gap, which is now just over the 4 million mark, which is a really positive space for us to be in, and I anticipate further progress in closing that gap over the coming month as well. Our forecast has also improved. When I was sat in the board last time, we were talking about upwards of 70 million. Our trajectory now would be to get to about 68 million, and there are £4 million worth of options and issues that we think we can progress to improve that position, and we'll cover those in the next paper on the agenda. But we are overly reliant on non-recurrent measures as a board to get to that 64 million potential position at the end of the year. And there's about 14 million of non-recurrent actions. And the progress we need to make now is on converting as many of those non-recurrent opportunities into recurrent plans going forward. And there are also some challenges that we're facing, particularly in terms of growth in drugs costs, particularly in primary care, but also in secondary care. They're real challenges for us, and medical staff costs in particular. And we're also seeing too much variability across the organisation, and that's highlighted in the report, and we need to address that variability, and we'll be progressing that through the escalation meetings that we have as an organisation. But these are all issues that I think take us into a planning conversation for next year, which is a really positive place for us to be beginning that planning conversation early on in the process. That's been a perennial criticism of the board, and one that we're pleased we're in a position to address now. Chair, I'm conscious that 64 million, if we are able to deliver that, is not itself the target control total which Welsh Government has set, and that still remains at 44.8 million. So the progress now to deliver and to build on the momentum for this year, to develop our plan for next year, I think is really critical. So we'll see how that progresses over the next few months. With that, happy to open to questions, and conscious there are a number of recommendations to the report, Chair, which probably warrant a revision at the end.
Great, thank you, Hugh. Just to remind all board members, we have committed to reaching the 44.8 million by the end of March 2026. So we have to ensure that we come down to our control total. And you'll know from the last meeting, one of my concerns about our spend pattern and profile is that largely, if we are unable to become sustainable inside this space, then Welsh Government will need to find resource. It may choose not to, but it would need to find resource to cover those costs. And my anxiety is that resource would come from other public services. There is not a pool of resource that can just serve everybody's needs. And I think we have a responsibility as a health board to recognise that anything more we have inside this space, because we haven't managed to achieve a controlled total or our balance, will come from other services, whether it's education, whether it's transport, whether it's local authority services. All those services we rely upon to deliver good health. So it's not the case that we can just disconnect ourselves or fragment ourselves from the wider public spending regime. We have to recognise that we have a responsibility to other public services as well to kind of manage within our respective budget. And for me, that's the thrust behind why it is so important that we achieve sustainability inside this space. Colleagues, members, questions or observations? Winston.
Yeah, thank you, Chair. Thank you, Hugh, for a really clear report. I think I'm encouraged that the indicators are moving in the right direction. I think...
Winston, bring it a bit closer to you. I think we're missing some of the things you're saying.
Is that better?
Yeah, if you just pull it a little bit into...
A little bit closer.
Thank you,
Is that
Winston.
better?
Sorry, yeah, thank you.
Can you hear me as well?
Yeah.
Oh, good. So I'm really encouraged that the indicators are moving in the right direction. But I mean, we must remember, which I think Hugh's mentioned, is that the Welsh Government are still expecting us to get to a £45 million control total.
Indeed.
And we're still quite significantly away from that. Having said that, I'm encouraged that we've nearly identified all of our savings plans to date. And I'm also encouraged, which Hugh alluded to, is that our underlying deficits moved from what was £96 million down to 80 million. And I just want to explore a bit more on that, Hugh, because I think that's where our long-term figures going towards. What's changed in making sure our underlying deficit's improved, and where do you anticipate further improvements to our underlying deficit as we go forward in the future?
Thank you, Winston.
Thank you, Chair. Thank you, Winston. Yes, our underlying deficit has improved, and that's testament to some of the work that has been ongoing this year, as I mentioned, particularly in reducing our reliance on agency staffing. Agency nursing in particular has been a phenomenal improvement in our performance. So we've gone from spending about £3 million a month on agency nursing in May of last year to £1 million in last month. There's still progress that we can make there, because that's still £1 million a month, but our trajectory now would be to see that reduce further still in the second half of this year. So we're building on the momentum there. Now, those improvements are recurrent in nature and make a difference to the bottom line. We are still over-reliant, as I said, on non-recurrent measures, and one of the tasks that I'm undertaking over the next 6 weeks is to review the non-recurrent savings that have been developed this year, and to challenge the organisation in how we convert those into recurrent opportunities, so that we can further make an inroad into reducing that underlying deficit down closer to the reported deficit. That will be a hallmark of an organisation that's got better control over the position, and will help us in that journey to 44.8.
Excellent, great. I assured the Cabinet Secretary yesterday that we would confidently work towards achieving our respective control total by March 26, and that we would hope to meet our projected spend this year. At the same time, I emphasise the fact that there are considerable risk around us doing that. And the risk often operates in spaces where we have no control. So surge, potentially, estate issues that we've experienced recently, such as the challenges of bronchitis and leaking roofs. All of those kinds of issues are not always within our control, but we have to respond to them. So the margin of failure here is significant in the sense that we don't have sufficient resource to cover those kinds of activities should we suddenly have to face that kind of difficulty. But I'm very grateful for all the work that you and the team have done, and also I can see across the organisation in terms of reduction of expenditure. I think it's heroic in an organisation that has not, for a number of years, thought about how it might try and reduce these costs in this particular way. So I'm grateful of that process. I can see there's a couple of questions.
I'm not sure my question has been fully answered. I think what he's described is that we've got greater control on our agency cost spend. But what I wanted to get to was what were the causes of our reduction to our underlying deficit, which is something to commend and celebrate, but also where are the future opportunities to reduce an underlying deficit from the £80 million, something close to the control total. And maybe that answer isn't so clear today, but I'd like to look at those particular areas that we ought to identify. So, for example, beds is a key area, and I think I mentioned in the last board meeting that if we can get more greater control of our bed capacity, for example, we know that there are a significant number of patients who are clinically fit for discharge. If we manage those more closely, discharge them out into the community or home or elsewhere, then that could be an area of grit. But I just wanted to get a sense of that. Because I acknowledge that our in-year financial position is what it is.
Yes.
But we can influence the future, and we ought to do that as a board.
Good challenge, Winston. I'm going to come to Chantal first, and then Dalit before I ask you to respond to all of your questions. Chantal.
Thank you, Chair. I think just taking on what Winston has said, and I commend the internal team for all of the efforts that they've put in. But it seems to me that because we are in that space where there are risks associated with it and it is fragile, I'm just wondering what additional measures would the internal team make in order to make good on what we said we were going to do and to reach that position by March 2026?
Okay, thank you. Dalit.
Diolch. Can you hear me? Yes. My question is quite a practical question, and it's about primary care and medicines in particular, prescribing, and there's an upward trend in the spend here. And I'm just asking if we are outliers and what is being done in regards medication and prescribing, or is there a national look at prescribing of drugs? Because if this is something that all health boards are experiencing, what is being done on a national level to really look at use of generics or etc. other methods of prescribing. So I'd like clarification on that work.
Good question. I know you're overloaded with questions, but I'm going to come to Anna first for time and brevity.
Well, Hugh, you'll be pleased to hear mine is probably a version of Chantal's, so you may be able to kill two birds with one stone. So, I mean, I too am curious as to this discrepancy between what we are projecting as a planned deficit of 64 against a target control of 44.8, and we use this word acceptable and unacceptable, and I think we are in the territory of de facto accepting the unacceptable, which seems to be a sort of
unacceptable thing.
Sort of,
yes.
Yeah, we're in sort of, yeah. So I suppose what I want to understand is what, you mentioned, Chair, earlier on design principles. I'm interested to know what design principles or assumptions or red lines would have to change to get us sub 64 million, and what evidence or confidence can we have that that target around March 26 is achievable.
Thank you very much. Good scrutiny, members. Hugh.
Right, thank you. I'll try and, I think I've captured all the questions, so I'll try and respond accordingly. Chair, you expressed your thanks, and I just want to, I guess, echo that back to the team. I think one of the big things that has really changed this year is that we have been approaching this very much as a collective. We've approached this very much as a team, and the plans that have come through have been a mixture of strategic plans that have been developed across the executive team, but also real engagement from a number of our directorates across the organisation. It's been a real change and has been very welcome to see. So that's where the big shift has happened. And that probably goes some way to answer Winston's question in terms of what's changed. That's been the fundamental change. I think the tone has changed across the organisation. We are thinking about value to the taxpayer as well as our duty to the patient and the population we serve. And I think that's really important and heartening. Just in terms of responding briefly to, I guess, Anna, your challenge and Chantal's, I guess we need the benefit of time to develop a plan now. And what we've not had in the past, we've tended to start our planning far too late in the year. And we go in partly because we're trying to address the in-year challenge before we can give ourselves the opportunity to think about our future challenge. So I think what will change, what is changing, is that ability to plan better and use that time more effectively. There are probably another number of areas that we need to get into and explore, prevention being an obvious one, managing the demand on our system being another clear one, how we deploy technology much more effectively across the health board to reduce the demand on staff is another one, value-based healthcare and how we shift resources accordingly to deliver best value is another theme that's coming through. And one of the areas that has been a very practical implementation this year is the rollout of Allocate as it's a rostering system for our medical staff. Rolling that out across the health board will allow us to get a better understanding of where there are opportunities in our medical staffing costs as well. So some real practical opportunities that we need to build on there. We are getting into a planning conversation in this discussion, though, and the paper is very much a look back. So I'm conscious that we probably need to bring something back in a more measured way that outlines what the planning framework looks like to address some of the very real challenges we need to approach.
And I would suggest to you that, linked to Anna's point, that needs to happen earlier rather than later.
Absolutely.
So if we are to plan well for next year and think much more strategically, that needs to happen this side of this year.
Indeed.
Excellent. Can I just take you to Delith's question about drugs?
Forgive me, Delith. So yes, in terms of drugs, we get comparators across the health boards, and I get a report back on that. So some very heartening comparators then. In terms of our overall primary care drugs expenditure, we compare very well. In fact, our position versus other health boards is looking very favourable. So that's good in primary care. and in the conversion of opportunities, so this would be in the use of generics and use of biosimilars as well, we are an early adopter of any opportunities that come through. So Jill's team has a very robust process of assessing opportunities, converting those into deliverable actions, and then operationalising those with quite short timelines, to the extent that I think we benchmark really well on our use of generics and biosimilars.
Thank you. You still have a worried look on your face.
Yes, I do actually, because I think if there is this upward trajectory, is it a national issue that we really need to think about for the NHS in Wales in particular, or if it's NHS England as well? And I just think there is an upward trend here, and whether or not there is something being done nationally.
So it's a national issue. It's probably an international issue, because what we're seeing here are global supply chains that are impacting us. So the inflationary pressure over the last few years has certainly made its way into the drug supply chain. And we're seeing the impact of that. But I would argue that's probably a very consistent issue internationally. There is more, undoubtedly, that we can do across Wales. Addressing variability is probably one area, which is where some of the comparators come through quite well, and maximising what we can do in terms of rebates and commercial arrangements with suppliers. We do that. We work quite closely across the UK as well in maximising those opportunities. But it is a one-way trend that we're seeing.
Thank you, Hugh. Thank you, Janet. Yes, please, Ewan, and then Michael, and then I'm going to close the conversation.
Yeah, thank you, Diolch Cadeirydd. It's more a kind of observation than a question, so to give you a bit of a break. But you mentioned, Chair, in terms of obviously if we don't realise the 44 million kind of headline target from Welsh Government, where is the funding going to come from, and potentially other public services? I think what is worth noting in terms of going back to a previous comment around the need to revise our strategy, which is obviously pre-COVID, I think what we're seeing now in terms of with the shift in terms of savings, which is to be commended within the Health Board in terms of everyone's engagement and commitment to it, we are seeing, I think, a ripple effect within the third sector particularly, because a lot of now kind of increase in demand for services from the third sector, our community voluntary councils across the 3 counties, and our independent kind of sector-specific or issue-specific projects are seeing huge upturns in terms of demand, and that is impacting on their costs and demands, which is the ripple effect, I think, from what we're seeing across the wider public sector piece. So I think it is just worth noting that whilst it is to be commended in terms of what we're achieving as an organisation, there is already a ripple effect in terms of the financial impact within our communities and on the third sector organisations in terms of prevention, which hopefully will be picked up in a revision to the strategy going forward.
That is a very good observation. We need to understand we operate as a system, so the decisions we make will impact into the third sector and communities in a very demonstrable way. So we do need to be mindful of that, Ewan. And I know that we undertake impact assessments in terms of our work, but the broader systems impact assessment of how community services or groups, third sector organisations are operating, feels to me we need to give that a bit more focus and attention. I'm not going to come back to you to answer that, okay, for the case of brevity. I'm going to go to Michael.
Yes, thank you, Chair. Just building on what some of my fellow IMs said, particularly comments of Anna, what the recommendation is this recommendation is it just me, or does it seem to be a bit anodyne, really? And so that's my comment. It might be something more for Joe to think about.
Why do you think it's anodyne?
Sorry?
Why do you think it's anodyne?
Because it talks about, well, recognising.
Yeah.
Well, I think, you know, we all recognise, but I think there's a slightly more, more concern, or more, something further than just recognising. I think is what that's my observation.
Yes, I clearly understand that we are being asked to recognise a situation which, as a board, we shouldn't approve, and we are in that difficult position. It's paradoxical that we're in a position where we're trying to work to an end game, but our current position is unacceptable. And I'm frankly, as a board, we have to not grow comfortable with that proposition, remain uncomfortable with it, but allow the work that the board is engaged in to mature and to remain vigilant over that process. So I accept your observation, Michael. It's well made. But I do ask of the board that we accept the recommendations in the financial report, notwithstanding the point you've just made, which we will minute as well as part of the process. This will lead us into our next paper, where we are looking more closely at the annual plan and financial recovery. So some of the reassurance we need and the process around escalation, which I think has been very helpful, will now take forward in terms of, I'm going to hand over to Lee to take this through its part of the conversation.
Great. Thank you very much, Chair. And yes, as you say, it very much follows from Hugh's update. So board members will be very familiar with the background to this report, in particular financial position, as we've just discussed, but also our escalation status. We've obviously been escalated to target intervention across all 6 domains of the Welsh Government escalation framework. In March this year, board received and endorsed the plan for 2024-25, which set out improvements, and we anticipate across all 6 domains. Importantly, this included a £64 million year-end deficit that we've just discussed. Whilst that represented a small improvement on the 23-24 end deficit position, it remained an unacceptable position for us, as we've just described, as it exceeds the target control total and is a breach of our statutory duty to break even, which we noted in that discussion. That said, a £64 million deficit did necessitate £32 million of savings, which is far in excess of what the organisation has previously delivered through savings, and therefore we did anticipate quite significant risks in its delivery. The board asked in March that we de-risk the financial delivery of the annual plan through Q1, and you'll recall at the July board we were advising that we hadn't fully achieved that by the end of that period, and a gap of 10.7 million remained. So considerable work has progressed over the summer months, including a series of workshops with clinical and operational leads to address that. The result of this work is the further improvement that Hugh was described, moving our forecast position to 68 million, but it then did leave a further 4 million to address to get to that 64 million position. To achieve that, directors have proposed a further set of actions, and we've instigated a further set of additional controls, as is set out in the paper. Board members had the opportunity to discuss this in quite a lot of detail in a board seminar earlier in the month. So I won't go through them in turn, but obviously we're happy to pick up any specific questions in relation to that. Finally, I guess coming back to some of the questions from independent members earlier, I think it's fair to say that whilst we've got increasing assurance on the delivery of this year's financial position, it does, as I say, remain a significant distance from the control total, and furthermore that position is reliant on non-recurrent savings. So the crucial piece of work for us over the coming months will be to consider, to identify and deliver savings beyond that, particularly moving them into recurrent where that's possible, and then to develop that plan, that route map to the target control total towards March 26. Clearly we've got uncertainty at the moment as to what the allocation might look like next year, so we're planning on the basis of delivering substantial savings as much as that's able to, but we obviously can't predict at this point exactly where that might take us to, but we've commenced that work anyway, and I just wanted to draw that to board's attention, that's going to be the critical next phase of this process. So happy to take questions there, Chair.
Great, thank you. I think this partly bleeds into the last item in terms of thinking through some of those issues. Very helpful. Hugh, did you want to add anything to that?
No, Chair, I think Lee covered it.
Great. Can I just, for the sake of my assurance, I note the work that we've been doing around escalation, and we've obviously created quite a vigilant and transparent approach to making sure that we can identify across the organisation where perhaps we feel we're not moving forward in terms of some of our cost savings or our aspirations. And there are areas of the organisation where that's apparent. And I wonder, what are we doing, as opposed to just noting that some parts of the organisation are failing to meet the controls or the dedicated spends we placed on them? what are we doing to ensure that those circumstances are remedied, or that those areas of spend are brought into line in terms of cost saving?
Yeah, I'm happy to start, Lee, if that helps. So the escalation status for each of our directorates is on the next paper, on the iPad, but in terms of the process, those directorates that are escalated at level 3, which is our highest internal level of escalation across a range of measures, we meet with them on a monthly basis. And it's probably taken 2 or 3 months to get into both us as executives around that table and those directorates that are being escalated to start to understand the issues in depth and then gain greater clarity over the answers that are being put in place. So there has been a shift in the responsiveness to escalation, and the last round of escalation meetings was a really positive round where you could see the sense of improvement across directorates. Not sufficient to de-escalate, but certainly a responsiveness to escalation that is heartening to see. There have been levels of intervention which have necessitated additional support to come in from directorates, so particularly around support on workforce, on digital solutions that might be needed, on planning and project management support. So they've been coming out naturally from those conversations and have supported directorates in developing further plans. And we see how that now will progress over the next round of escalation meetings. And I do hope that we'll be in a position to de-escalate some directorates over the autumn.
Yeah. Lee, did you want to add anything?
I think Hugh's covered it. Obviously, we do, through those escalation meetings, consider all 6 domains, and I think our general consensus would be that we've seen a similar response across all the domains, and in most areas they're moving in the right direction. At variable speed, I suppose, is a fair summary, though, so we're trying to support those that are further away from where we want them to be.
Great, thank you very much. Okay, I think organisations often underestimate how much of this is a learning exercise. It's learning to think differently about resources. And the more that we can encourage the organisation to build that kind of business literacy, I think the more that we might see degrees of compliance we haven't seen hitherto. Colleagues, I'm presuming you're comfortable with that. I see no questions.
There is a question.
Winston.
Yeah, so I think, again, we've made quite good progress in relation to identifying plans to get us to 64 million. I just want to have a look at the variable pay section is of concern to me. I think we've done extremely well in nursing. It's interesting, I'm sat in between the medical director and nurse director, so that's a good thing. We've done really well in terms of nursing, and we continue to build on that success. However, I am concerned about the medical variable pay position, because reading the paper itself, for example, due to safety, I'm quoting from the paper, due to safety and quality impacts, there are currently no exit plans to replace doctors in Glangwili A&E and mental health and learning disability service. That's fine for the short term, but for the long term, surely we must have exit plans or something towards replacing that situation.
Yeah.
Because of quality and safety concerns. So I guess my challenge, my question is, do we have a plan, and what would that timescale look like? Because we must be spending extraordinary amounts of money in order to maintain and prop up those services.
Eye-watering.
Yeah.
Eye-watering, which is just problematic in the current climate. Lisa, would you like to respond to that?
Yes, certainly. I'll make a start, and I'm sure some of my colleagues will contribute. So in terms of medical workforce, what we have seen is a significant improvement in agency medical workforce. So we've gone from a relatively high number of agency doctors to a number now where we're going to be reduced to single figures by the 1st of November through the plans that we have within our services. What we haven't got with our medical workforce, which was mentioned earlier, was a rostering system. So with nursing, it was very easy to be able to look at where the deficits in terms of the substantive workforce were, why we were using different locums or additional hours for individuals. With our medical workforce, we will start to roll out the medical rostering system. So we have a couple of services who will be the pilots for that. We'll take very early learning from introducing the rostering system there to replicate then across the organisation. The other thing that we have as well for medical workforce is a rate card. So how much do you get paid if you work additional hours? And that rate card varies from professional groups in terms of staff locations across NHS Wales, whereas Agenda for Change is very standard across the whole of Wales in terms of what people get paid. So there's focused work. Now we've made the improvements on our nursing variable pay. The team will be shifting their priorities to medical workforce and supporting the medical directorate in terms of how we can do that. We've also got some overseas recruitment in November. A member of our recruitment team will be part of that appointing team, and we'll be looking to see if we can recruit from overseas for any of the areas where we have got regular use of variable workforce.
Thank you. I'm looking at you, Mark. You do not have to say anything. You do not have to say
I'm
anything.
poised, Neil, I'm poised. Yeah, thanks. It's a very good point. And thanks, Lisa, for describing the changes that we can make within our control within the Health Board. And I think we are increasingly getting more grip and control over how we manage our agency and our variable pay. And we'll see some changes and I think improvements very soon. I think we have to recognise that there are other issues within our control. What drive the issues with our medical workforce, that will be our configuration. And we all know that our configuration, multiple rotas over multiple sites, means that we will always struggle to recruit. We also have to consider national training and recruitment issues that directly impact on us. So we do have plans, and as Lisa described them, in terms of wishing to continually try to recruit, but ultimately I think our how we deliver our service and how we structure our service is the long-term solution to actually having sustainable rotas. But I think the medical workforce planning has lagged behind the excellent work that has been done in nursing. And the good thing for us now, which is an unusual position for doctors, is that we are learning from nurses, which is fantastic. So I'm convinced there's going to be a lot of improvements in the next few months.
Excellent, good. And I suspect, going back to Anna's point about thinking strategically about our cost reduction next year, that will be a central pillar inside that space.
And if we think about it, our clinical services plan is significantly about our fragile services, which are linked to significantly linked often to medical workforce issues. So as we progress through those, we're hoping that we will see some more stability.
I'm pendant. Rodri.
Yeah, just on another point, if you look at the paper and the further opportunities, just the regional working, I think that's, I think that is something that we were thinking we were going to do some inroads on, but doesn't sound so positive from that paragraph. And I just want that assurance that there is that regional working kind of as one of the further opportunities. But how advanced are we? Are the discussions happening, or have things been delayed for some reason or other?
Good question. Yeah, yes, please, Andrew.
Yeah, thank you for the question, Rodri. I think the regional space is one that continues to be an area whereby activity is increasing, I guess, and plans are developing and evolving. We're very active in conversations with Swansea around the delivery of orthopaedic services and regional network, for the development of a regional network for pathology, which is an area where we've got a number of high costs, where we incur a significant amount of high cost variable pay. And we're also in the process of establishing a similar, more formal arrangement around ophthalmology that's being led by my colleague in Swansea. We're anticipating we'll probably have a clinical workshop over the next couple of months based on conversations we've had this week to really explore the opportunities and benefits we might be able to get into quickly in that space.
Thank you, Andrew. And Rodri, you'll be aware on 17th of October, the two boards, Swansea and Hywel Dda, will come together to think about our long-term approach to joint working. And I think that will help enormously identify future opportunities for the two boards to work more effectively together and address some of the challenges we're both facing. Very good. Okay, can I assume that board members can take assurance from the paper that's been prepared on this matter and Lee's presentation? Yep. Okay. Let us move then to the integrated performance report. I've kind of partly referred to this already, but Hugh, anything that you would want to bring to our attention?
Yeah, diolch Cadeirydd. I won't speak to every individual issue that's highlighted there, but recognising that in not doing that, that doesn't diminish the importance of the issues. But I think the report speaks quite clearly, and I think the new format of including alert, advise, assure, while it wasn't necessarily designed for reporting purposes, actually has been really helpful in providing some clarity over the concerns that we want to make sure that the board are familiar with, and no doubt we'll get into discussion on the mitigations to some of those issues. I just wanted to highlight a couple of things. On page 5, we've continued to bring to your attention how we triangulate some of the data that we're reporting. This is a numeric quantitative triangulation. It's not a qualitative triangulation of the data that we're seeing, but we do see some variability across quality, safety and risk measures that's highlighted on page 5. And some real positive things that we've already talked about in terms of improvements in workforce metrics that we're seeing, apart from long-term sickness, which is a concern which I'm sure we'll come back to, and some positive reflections then on the financial metrics given our reduced reliance on agency. Our escalation status, which we've already spoken to, Chair, but I think it's helpful just to have sight of it, is highlighted on page 6. I'd probably split this into 2 chunks. Quality, governance and workforce metrics that we are measuring against are mainly process measures, and the finance, fragility and performance are either contextual or outcome measures. I think in terms of the nature of the escalation meetings that we've had, reduced tolerance, I guess, over the quality, governance and workforce metrics, because they are largely management actions that could help us unlock and de-escalate directorates in those spaces. But I recognise that there is something much more inherently challenging around addressing fragility, performance and finance. Chair, with that, happy to open up to discussion.
Colleagues, observations or questions? My observation would be, sorry Chantal, I'll just show it and then I'll invite you in, and then Anna, is that there's a pattern. So often those where we see underperformance, we also see challenges around finance and we also see challenges around workforce. So when you kind of start to place a lens on some of these services, there's a pattern of those who are bits of the organisation that's not optimal at the current time. And it's not just in one space, it's in several spaces. Their challenge to develop that optimality. So I think that should form the basis for when conversations about escalation or de-escalation take place, Hugh, that it's a combination of things, not just one thing that's leading to those parts of the organisation not delivering as we would want it to. Great. Chantal, and then I'm going to come to Anna.
You've got Delith as well, Chair.
And Delith.
Yes. I was interested in the staff sickness, obviously, because I chair the People's Committee, and in particular the comment about that a number of staff are being absent due to anxiety, depression, etc. I mean, we have a very well-developed staff well-being approach within the organisation. I'm just wondering whether we are signposting those who've already gone off sick to those measures that we've already taken internally within Hywel Dda, or what support are we giving to those individuals, given that they are suffering from anxiety, stress, depression, etc. Thank you.
Shall we, Lisa, I would come to you, but let's take the other questions first, and then just in case there's anything else that refers to what you want. Yes, please, Anna.
Thanks, Chair. So I've got a question about the escalation overview, and caveat this by saying, obviously I'm not involved in the detail of the process, so you may be able to provide some assurance with some more detail around this, and also recognising what you've just said about tolerance levels shifting. Nonetheless, when I read this, and I don't think we've seen this reported in this way previously, I was really quite taken aback to read that 3 of our key pathways are in this state from an assurance point of view, particularly noting that 2 of those pathways, women, children and mental health and LD, are known to be particularly high risk areas of our clinical portfolio and disproportionately feature in other organisations high-profile reviews when things have gone catastrophically wrong. So to see that we have women and children in all 6 domains with that no assurance categorisation, and mental health and plan care with five of the 6 is I find quite alarming to read that cold. So I suppose I'm interested in, one is, how did it come to this? And 2, whether a monthly executive scrutiny is proportionate to the verdict that appears to have been reached in relation to levels of assurance on those directorates, please.
Thank you, Anna. I'm going to come to Delith, and then we'll take a response to the questions.
Diolch, Cadeirydd, and my colleagues, esteemed colleagues, have asked 2 of my questions, because I had a page of questions, to be perfectly honest. And the escalation issue is a really concerning one for me, but I'm sure you will answer that one. There's a positive in regards to the ambulance handovers. However, with the pressures that will come in winter, I'd like to know what mitigations are in place going forward through the winter months. So that's one point. The other point is about children and young people with the child neurodevelopmental weights. And I'm really concerned to see that we only have 16%, just over, slightly over, 16% of our children and young people having ASD assessments. Now, that is a really concerning figure for us as a health board to read, and I just want to know what other mitigations are in place for us as a health board, but nationally, to look at the ASD issue particularly.
Great, okay. So let's take Lisa first in relation to the sickness absence question.
Okay, thank you. So in terms of stress-related, anxiety-related sickness absence, we have 2 work streams really. One is around treatment, so for individuals who are currently experiencing high levels of anxiety and may or may not be off sick. And we also have upstream work around how we support individuals to remain well. So some of the resources that are available are, we have now an online staff wellbeing portal which connects people with our occupational health service and our staff psychological wellbeing service. There's now one point of access to the 2 areas. In there, people will find resources which are toolkits around how to maintain positive mental health. There are guides for managers around how to support individuals who are in need. There are webinars that people can watch as well. We have a stress risk assessment and encourage individuals with their managers to complete their risk assessment, and then they can work together around how they support people. We have wellbeing at work resources that are available for staff. We have a recovery in nature programme, so for people who are particularly suffering from burnout, there's a very small cohort of individuals who are supported by our staff psychological wellbeing manager. We have face-to-face appointments for individuals internally with our staff wellbeing service, or they can contact a 24-hour helpline and have counselling support there, and that does offer a series of interventions for individuals should they choose to take those. The other piece of work that we do then is, if people are off sick and are off for a long time with this, with stress or anxiety, we have conversations with them as part of their sickness reviews around a return to work. Now, it may not be their workplace and it may not be to their current role, but we explore opportunities for individuals to return to a different role in a different place. And with our trade union reps, we have a working group around that so that we can get people back into a workplace, because being off doesn't help. So there's a whole range of things to treat and support individuals in and their managers in the moment, and also support people from remain well. Is that okay?
Thank you, Lisa. Thank you.
I suspect, Chantal, it's a global issue, not just an issue that I'm sure, Diana, you'd agree with that broadly.
Yes, in fact, all across England and Wales, NHS staff absence due to illness, the leading cause of staff absence is psychiatric mental health, anxiety, accounting for well over 25% of all staff absences. And Lisa highlighted the range of the support that we do put in place for our staff.
Right, okay. That shouldn't excuse us in terms of our level, but it should make us vigilant around what we can do, and always what we can do inside this space. Hugh, I'm going to come to you in response to Anna's question and Dennis. You may need to draw on somebody else's support, and then I'll come to Rodri for the question.
Yeah, thank you. I'll hand over to Andrew to answer Dela's questions, if I may. But just in terms of the overarching framework we've got here, putting in an escalation process is something that's relatively new for us. So we're learning. And we're learning as we go through this process. And I think this first year, in the first couple of quarters of this year, we've learnt a huge amount that we'll build upon now as part of our planning for next year. And of course, the more we shine a light on an issue, the more we see. And the brighter the light, the more we will see through that. So there has been a process of issues being escalated and highlighted that are then being addressed in a measured way as we learn from that. Each of the domains within which we measure has a professional lead. And what I'm very conscious is that each professional lead has the responsibility to measure the escalation status for each directorate. So any particular concerns that professional lead would have would be escalated and highlighted through assurance committees. So this doesn't contradict the processes that we already have for professional leads to make sure that issues are brought to the attention of relevant committees and into the board. I guess there's specific reflection in terms of women's, children's and mental health services. And what I'd say is our assessment at the moment is quite a high bar, rightly so. And is largely a numerical assessment. So we've set a bar, set a standard, and if that gets missed, then clearly escalation follows. We have seen with those two directorates some real structural challenges, some operational challenges, some challenges in long-standing challenges in recruitment that naturally then reflect across a number of domains. So that has been reflected in the overarching understanding. I guess our reflection, we had a meeting yesterday with operational colleagues where we reflected a little bit about the learning from the first 6 months. And as I said, this has been largely a numerical assessment. There is something about how do we triangulate into this, more of the feeling, more of the intelligence, the soft intelligence into the escalation process. And we'll reflect on that as we think about how the escalation process then matures going into next year. Hopefully that gives you a sense of assurance of the process we've got. In terms of the response to escalation, that support is from each professional lead as part of the escalation meetings. Having meetings, there's a balance here between the regularity of meetings and the impact of meetings. And I'm concerned by having meetings more frequently than monthly, that directors won't have the ability to then respond to the challenges we've put in place, the actions that then need to be taken, and make sure they're being embedded. Because what we want aren't necessarily quick responses, but responses we know that can be sustainably kept up with. We don't want directorates that get de-escalated and then escalated again quickly because the response hasn't been sustainably implemented.
I agree. I mean, I think so. We need assurance at two levels. We need assurance that there's appropriate level of scrutiny. And as you've described the escalation process, it would seem the case. But we also need assurance that there's traction inside the system. So actually changes are taking place as a consequence of exposure to where some of these suboptimal activities are taking place. I think we need that. You know, we need to be assured, rather than just seeing a worrying picture of where we think services are suboptimal, we need to know and be assured that actually plans are in place and we are seeing incremental improvement against each of these 6 areas.
And if I may, Chair, I think you want to come back in, Anna, but if I may, we'll reflect on that in future reports so that you can get that assurance of the actions that are being taken from one month to another, because I think that should provide that level of support.
We would want to see progress.
Yeah.
Anna, has that addressed your issue?
Just very briefly, I can come back on that, Chair. I mean, I think I would reserve judgment as to whether I feel assured by that or not. I take the point about learning. I think there's still a question about we need to learn how we don't get back to this point ever again, because if it's this bad and we're only just articulating it, that is a failure in our own governance arrangements. And I'm not suggesting for one moment that you necessarily want to increase the frequency of executive scrutiny, but I am wondering whether we have the capacity and capability in place to turn this around. And although I hear you describe this as a sort of an assessment against a numerical set of metrics. A, they should be reasonably reflective of what goes on in those services, otherwise they're not worth measuring. And second, as the Chair has highlighted, these patterns will suggest other things. It's unlikely that in the numerical metrics we'd be poor, but in every other respect we'd be fine. There's something nonsensical about that.
Yeah.
So I think I will accept the assurance on the basis that this is an evolving picture, but I will certainly want to return to this and think about what that means through the committee structure that we have too, in terms of what assumptions we may be making or not making about the day-to-day operations of the services.
Thank you very much. I mean, I think I think we would probably agree with your proposition there, in terms of what would be acceptable. I think this is partly driven by the fact we are suddenly seeing pictorially data that worries us in a way that we might not have seen this data before. This feels to me like a classic controls assurance process. We are trying to seek that assurance that everything is controlled and managed inside the space. But I share your view. It is alarming when we see that some parts of services are truly suboptimal.
Absolutely.
Right. Darren's question, which may be that, Andrew, you can answer, but you might want to go ahead. And then Lee, and then Lisa, and then I'm going to close the session.
Okay, thank you, Chair, and thank you for the questions, Delith, as always. I think, so I am pleased you've identified the issue of ambulance handovers and the improvement we've seen. I think from a health board perspective, it's a significant health-wide level, it's a significant improvement on where we've been for some time, but it is driven in large part by some really significant improvement we've seen across Pembrokeshire and at Withybush Hospital. That improvement has been led by our senior clinicians on site in Withybush, across the community and primary care, with good collaboration with Pembrokeshire Local Authority, and we're seeing a level of handover delay and performance at times through the last reported month that for 8 days in a row there were no ambulance handovers over an hour, and actually our performance was closer to 80 to 90% for handovers within 15 minutes, which some board members may remember, if they've got the memory, that was the original target some 7 or 8 years ago for NHS Wales. So there are some really encouraging signs, and that, as I say, that's been clinically led and has been based around a significant level of pathway redesign and change both across community and the hospital to avoid admissions, discharge patients quicker, and assess and treat patients and discharge them as quickly as we can before they get to the point whereby we know they tend to get stuck. So the acute frailty unit, for example, in Withybush has been a key component of that. As we go into winter, obviously the demand pressures are always there. What we're trying to do and attempting to do through our 6 Goals programme, which I think is more successfully embedding in local operational delivery the actions required to shift the system and improve performance and experience for patients and quality of care into day-to-day operational business than we've seen previously, is to make sure we roll out some of that learning from Pembrokeshire across, in particular, Carmarthenshire and Ceredigion. So that's going to centre around how we continue to build on our models of community care and enhanced care in the community, continue the work with our streaming hubs that we've got that help filter patients and avoid them having to attend hospital at all, provide them care at home, and work with our local authority partners to better facilitate discharge. We have also, within that space, seen a reduction in pathway of care delays, which I know have been a significant concern for the board. And the data, although not validated yet for September, is indicating we'll improve further again. So we will be, for the first time, or for the second time this month, we'll have achieved our TI, target intervention de-escalation criteria for pathway of care delays improvement, as well as hopefully our handover delay position, because it was the first time we've been on track with our handover performance improvement trajectory. So our plan for the winter is really how we make more resilient the services we've got, but also roll out the learning and implement those, particularly the straight to specialty pathways that we've seen in Withybush that have had such an impact in freeing up the emergency department team to do what emergency departments need to do. On the neurodevelopmental service question, again, I know this is an issue that's been a concern for the board for a long time. It's been a concern for me and the service. It's interesting, or it's notable that in the last 3 months, Welsh Government have removed this from our targeted intervention escalation performance discussion in recognition of the fact that they suggest that no health board in Wales will ever achieve the target as it's currently set because of the way the system and the pathway works. They believe, therefore, there's a more strategic solution needed at a national level to address the issues we're seeing, and so the scrutiny this now gets as a performance measure in our national discussion is quite minimal. What I have asked, though, locally, is for the team to consider a couple of things. One is, if the measure currently doesn't give a good indication of what's happening, what would be the right measures that we could be looking at to provide some assurance to the board as to the access to the service and the quality of service we're providing. And also, we are really engaged with the mental health network nationally, mental health and disability network nationally, around wanting to be involved in any potential pilot that emerges for this service area. And we've got a meeting with the Mental Health National Network Director next week to explore that further. I think it's an interesting service because it feels like it lends itself to a different model, in that 85% of referrals we receive actually end up with a confirmed diagnosis of a neurodevelopmental condition. The trick is then how we identify within those referrals the 35% that need specialist care, as opposed to the patients and children that need support and guidance for managing to understand how to manage their condition and how it might impact their day-to-day interaction. So it's an area where I think there could be some exciting opportunities to test new models of care, and that's a conversation we're progressing with national colleagues next week.
Great. I'm conscious we have a number of questions. I'm going to ask, are they particularly urgent, or because we're running short of time?
I was going to add further context to Anna's question, but I'm happy to take that offline if that's...
Great, okay. We may come back to that when we're reporting later. The case may be.
Mine was the same, so I can pick it up separately as well.
Rodri.
I just wanted to pick on 2 points. Just back to the staff sickness quickly, 6.6%. So just to understand, so this percentage, they're not all off sick. I just want to, what is the clear percentage of those that are off at any one time? And what percentage do you budget for in any financial plan? Because I suppose there's a cover element there that would cost the when we're looking at the financial plan and to the health board itself. That's one of the questions. And the other one then, ophthalmology. I can't really not raise that. We've looked at it in ARAC here, but looking at this, performance now lower than any time since February 2020. It says that there are mitigating factors or areas that you have hopefully found some kind of a solution to. Some of these dates have passed, and I just wanted to see, is there any progress? I know you've mentioned Swansea Bay, but is there any progress on this and the mitigation that you have put in place?
Right, 2 questions. Let's just deal with the sickness absence question first.
Okay.
So if there's correlation as well to department specialisms to where the sickness is occurring.
Okay, so the first part I can answer relatively easily. We track 2 types of sickness absence. One is rolling sickness, so 6.6%, so that looks back over a 12-month period and calculates the rate. The other one then is in-month sickness, so for August it was 6.13. So what you will see is the in-month will obviously fluctuate. It will take a longer period of time for any sickness to reduce if you've had, as in this report, a series of months where sickness has increased. So one drop wouldn't change that one. So the 6.13 is actually the people who are off sick. If you work that out based upon our head count, that would tell you how many people were off during that month. What was the other part of that question, sorry?
No, just the other part.
Oh,
is
the
kind of
headroom. It's around 5.2%.
5.2.
Yeah, so anything over and above that would not be counted in the headroom position, so would cost more.
Okay, so 5.2, that is the base figure, right, to get headroom then.
So it's 1%. The cost is around 1% once you remove the headroom.
Yes.
Okay.
Okay.
Rodri, are you reassured by that?
Yeah. Yeah, no, that's fine. Now, ophthalmology then.
Ophthalmology, yeah, no. So on ophthalmology, Rodri, the challenges, the service have been balancing a real challenge of how they balance their available workforce across and capacity across emergency, urgent and routine eye care pathways. We've been successfully recruiting some new SAS doctors in September, so they will provide additional R1 capacity going forwards. As you will have heard in the board seminar, we have a very engaged optometrist community, and our plans heavily involve the rollout of an enhanced level of provision by our optometrists that will help avoid referrals into the secondary care service and look after more patients in the community, which will provide additional routine R1, additional R1 capacity within our core clinic templates. We have established the one-stop cataract pathway, which has two impacts. One, it helps mitigate and improve our 104-week wait and 52-week outpatient wait position, but it also, by definition of being one-stop, frees up capacity as well, to support which we are redirecting into looking after and managing the R1 capacity, R1 patient capacity deficit. And in the last month, we've also recruited one substantive and one NHS locum consultant to the ophthalmology team that will help bring some additional capacity. So we are making progress. We still have more progress to make to be able to get a service whereby we've got a workforce capacity that will meet the need of the population, which is why the regional conversation with Swansea becomes really important for us.
Thank you.
I think we need to see these plans mature.
We do.
Truly, and accelerate the conversation with Swansea in terms of the art of the potential at that point. Thank you. I'm going to close the item at this point. Notwithstanding what Anna said at the start, which I think was a really useful contribution, we are asked to take reassurance from the actions that are in place to address where we are underperforming inside this space. And I think what we need to do, we will take assurance from the structure and the design and the methodology that the organisation's using to expose and highlight where performance is suboptimal. What we need, Hugh, is to seek assurance around the delivery against those observations. And perhaps when we come back to the next board, we could start to look at that picture. But I appreciate it's a new system in place, and it takes a while to be able to see these changes embed as part of that journey. A good journey, but we need to see some impact and traction. Great. Okay. We're about to take a quick break, but before we do that, can I just turn to the Corporate Risk Register?
Me to take that one?
Yes, please, Jo.
Yeah. So thank you, Chair. So since the Corporate Risk Register was presented to the board in May, the risks have all been discussed within the various board level committees. So to give some assurance to our members of the public, they have been gone through in detail. They're also reviewed prior to committee by what we call as an exec risk group. So the executive team go through each of those risks on the Corporate Risk Register. What we see through our committees is where assurance is not provided, where the committees are being mitigated or managed, additional assurance will be sought, and then that results in a different paper going back to the committees, and that particularly links to our quality committee. So currently we've got 21 risks. There's 3 new ones which are detailed within the paper. 5 have been de-escalated, 2 increased and 1 reduced, and 15 we've got no change, Chair. You will see in the paper that there are 3 risks that I have redacted, and that's due to sensitive nature, which they will be discussed within our in-committee session this afternoon. And also, just to flag, following discussions at the committees, 5 of the risks, which are again detailed within the paper, are currently under review, following feedback from the committees and also following review by the executive team. I just also wanted to add, because of the nature of the discussions that of the board which will follow after the break, what sits within underneath this as well is our directorate risks, which are also reviewed by the committees at points in time. And there are a significant number of risks at that level that are a level 20, which we call as an extreme risk, which links to the next 3 papers on the agenda. So it's just to highlight we are carrying a significant amount of risk, Chair. I'm not going to go through the risks because we've done that in the committees, but if there is anything specific on each risk, happy for each risk owner to take the questions, Chair.
Great. Phil, did you want to add anything?
No, I think that covers it.
James, you don't note that you are taking responsibility for some of the newly emerging risks.
Yes, that's due to changes in portfolio, Chair.
Excellent, good, okay. As Joe has highlighted, we are running significant risk, and both in terms of probability and impact, these risks run high. They are beyond our tolerance in a number of places, and we need to receive that assurance that mitigating actions are in place to manage down and reduce those risks. And I think there's evidence of that, but we need to be really vigilant around these risks. They are considerable for an organisation, and my anxiety is sometimes when we got lots of risks, we become a bit complacent about them because they just appear as extremes on a graph or on a graphic. The issue for us is to take them deeply seriously and to ensure that those who are owning the risks work on a regular basis to reduce or mitigate that risk. All the execs are looking at me in a very worried way now, but it's not something that we are going to remain vigilant about and continue in the future. Okay, can I suggest what we do is we take a 10-minute comfort break and then we'll resume with at what's the time now? It's just
11:25, Chair.
We'll reconvene at 11:25. Thank you. Sorry. Great. Okay, I think we're. Thank you for coming back so quickly and on time. We said 11:25, and it's 11:25. Thank you very much. The next three items relate to service change or proposed service change, and I take us back to the conversation at the start of the day, which was about using a set of design principles that ensure that we are consistent in the way in which we deal with issues. Those design principles are about safety and quality, they're about sustainability, they're about being fair in what we're trying to do, they're about not creating an unwelcome precedent inside this space. And I'd want us to bear that in mind when we think about these three potential service changes as we move forward. Also to ensure that we are evidence-based. So if we are in a position of having to make a difficult decision, we can do so on the basis of the evidence and the data that we've received and considered, which is the most important thing for us. We are not here necessarily to be popular. We're here to make the decision that we think is the best course of action we need to make at any particular time. Having said that, we need to be considered in our approach to understanding how any changes that we take forward will impact upon communities, on patients, on those who desperately need our services to be delivered well. So holding all those things in mind, I'd like to begin the next three items. So the first item is changes to Kilgaren and our intended progress in the Tregaron area, and also the reduction of potential reduction of beds at Tregaron Hospital. Andrew, I'm going to hand over you to start.
Thank you, Chair. And first, before I start, I'd just like to welcome Peter Skitt, who's the County Director for Ceredigion, and Tracy Evans, who's the Head of Nursing for Ceredigion as well, who are present for this item and will be able to support any questions.
Welcome both. You're well received.
Okay, so my plan is to, I'm going to assume everyone's read the paper. There's a few messages or points I'd like to give as part of presenting the paper and opening the discussion, and then I may, if I'm permitted, give Peter and Tracy the opportunity just to add anything that they wish before we move into questions. So colleagues will recall the discussion we had at our last public board meeting when we agreed to enter a 4-week period of engagement with the local population of Ceredigion on plans to accelerate delivery of the clinical service model that was at the heart of the Kilgaren project. The paper presented to the board today shares the key issues raised through that engagement period and the service responses to those issues. It's worth noting that during the 4-week period of engagement, 210 responses were received through the various events held in person and online, survey responses submitted, and via letters, emails and telephone calls received by the Health Board on the matter. It is very clear from those responses that there is understandably a large affection for Tregaron Hospital within the local community, with the majority of responses received reflecting on the excellent care loved ones, family members and friends have received at the hospital since it first opened. It's a credit to our staff, I believe, that they have been able to continue to provide that level of care for so long, and I'd like to take this opportunity just to thank them for that. As a board, we agreed a strategy in 2018, as I think you referenced earlier, Chair, that's centred around caring for people as close to home as possible, enhancing our provision of community care and reducing our reliance on inpatient hospital beds. Key parts of the case for change at that time included the increasing workforce fragility we faced then and predicted would get worse, and a deteriorating estate for the provision of some of our inpatient services and healthcare services that were no longer fit for the purpose of delivering modern-day healthcare. The strategy made it clear that we would need to change our models of care to meet these challenges successfully and maintain the safety of our services. Unfortunately, we've reached a position where Tregaron Hospital is now an example of a service for us, where we've been unable to recruit into qualified nursing posts despite our best efforts, making the ability to staff the beds in the hospital safely very fragile and increasingly difficult. And the building is also of an age and design that it's no longer suitable for the delivery of inpatient care. It could, however, provide a really good hub for community-based nursing teams and outpatient-based clinics as part of a new model. The proposed new model has already been tested to some extent within the Health Board in the south of Ceredigion, with the model that we established around Cardigan Hospital and the enhanced community care outreach team that links into the same-day urgent care service and hub there, which has been really successful in treating patients closer to home. This change, as proposed, would enable us to deliver the same quality service consistently across the county of Ceredigion. It will treat 4 times as many patients in the local community as we could through the current and existing inpatient capacity. This will help reduce hospital admissions, speed up discharge from hospital, support bronchitis better and mitigate some of the emergency pressures we're seeing. As we approach winter, it's important that we take steps to address the service fragility and support the overall resilience of the Ceredigion health system. In bringing this to the board today, I recognise that any change of this nature is hard and difficult for everyone involved. The operational and clinical view is that we have good evidence from the experience in South Ceredigion that accelerating the implementation of the clinical health model within the Kilgaren project will enable us to provide better quality and safer care to more patients closer to home with better patient outcomes. This is completely aligned with our clinical strategy and Welsh Government policy and ensures we address the safety risk caused by the fragility of the workforce. If I may, I'd like to just now offer Peter and Tracy the opportunity to add anything that they may wish before we go into a discussion and questions.
Thank you, Andrew.
Thank you, Andrew. And just to take the sort of fragility one step further, and I think it is really important to commend our staff in terms of having kept the place running to the point that they have at the moment. It isn't to be underestimated the amount of text messages and WhatsApp group messages that go out every single day to people to work extra shifts and extra hours. And that has been, an amazing achievement by the staff that work there at the moment, and I'd like to thank them for that. The second thing is that, of course, we do have the model in the south of Ceredigion, as you rightly say, and to some degree we're seeing this as an opportunity as well as a threat, because it does enable us then to get equity of service across Ceredigion and make it the north equivalent to the south. So it's important for us to. It is really challenging, isn't it, to go through this process and go through this with our public and our staff. It's been a challenging experience and it's been really, really difficult to get to this point. But it is, I think, important for us to see both the fragility of the service and the issues that were surrounding that in terms of the paper that's in front of people today, but also see the opportunity that this brings us as well in terms of caring for people in a much more appropriate way.
Thank you, Peter. Tracy.
Hello. I think it's just to echo really what Peter has said and to really focus on the wider community nursing services, which have been greatly impacted to some extent with us having to pull nurses into Tregaron to cover, which then obviously affects the wider population. So there has been times where we've had no night service for community nursing, which then affects those patients, and obviously our out-of-hours GP to have access for those who may be palliative, may need that additional support, may need that additional pain relief at night. Another example would be block catheters, which are extremely painful, and where patients are then having to be conveyed unnecessarily into hospital. So I think the focus as well has to be on the effects on the wider community nursing services and what we can provide.
You make a good point, Tracy, which is about how we're having to take from other community-based services in order to ensure that we've got appropriate staff at Tregaron. Thank you very much. Iris, do you want to add anything?
I don't think I have anything to add. I'd echo everything that's been said by Tracy and Peter. If you have to pull staff in from the community to support a hospital, then you are robbing the greater population of the community.
Great, okay, thank you. Colleagues, a contentious issue. I mean, anybody who watched the TV coverage last night, people love their hospital. They love Kilgaren, you know, and they've got lots of good memories about it. So it's a significant issue locally. Dennis first, Michael, Anne, and then Winston, and then Chantal. Did you want to? Okay.
Diolch, Cadeirydd. I'm not sure if Sharon wanted to come in just before me.
Yeah.
I'm not sure. You did have a finger up, didn't you?
I did, yeah. Thank you. And thank you. I think Tracy has covered
Sharon.
what I was going to say.
Pull the microphone towards you, Sharon.
Tracy's covered a lot of what I was going to say. I just wanted to assure the board, really, that the quality impact assessment has been to the panel. The risks...
Can you put it a bit more forward too? Because I think that's really important.
The risk scores were quite significant based on the current service that's being provided, and the mitigation that's being proposed does reduce those risk scores quite significantly. The other thing that the panel requested was a full equality impact assessment, and that returned a positive rating. The only aspect that is ongoing and is a live document is to ensure that the staff engagement continues. And I think it's important to note that the staff are providing an excellent service at the moment, but the fragility and the sustainability is getting increasingly challenging. And the panel were quite concerned about the fact that nursing staff were doubling back on shifts to provide cover during the night. So they would come in and work a morning shift and then have to double back, or as Tracy has said, we have to pull staff in from the community nursing team to provide the cover. So, so the panel approved the quality impact assessment that came through to them.
Thank you. Very helpful background. So I'm really sorry I've forgotten the order of questioning after that.
Chair, you should know I go first.
You always go first, Dennis. Yes, go ahead. I think Winston wanted... Winston, did you want to come in?
I did. It was really quite a quick question, really.
Let's go to Dennis first, and then back to Hugh, and then I think on Sam, I think you want to come in, Michael and Anne.
Please don't ask me to repeat that in the order, all right, because I haven't got it. I've got two questions, really, and as our chair has rightfully said, there is a lot of public discontent, public concern, and in the paper itself, you haven't quite articulated what you've shared with us today. And as a board, I'm really grateful that you have articulated that and bringing it back to quality and safety, but also bringing it back to equity. And I've got a question about the project milestones target, because as a model, this is hanging on actually having a Kilgaren model. And I'd like to know if we are aware of the tender applications for the actual build, because I am concerned that we haven't got anything in place. The second question I've got to ask, and I'm really conscious, being a nurse myself, that it's different working in a ward environment to working in the community. And Tracy, you've mentioned that community staff have had to help our colleagues within the hospital setting. But can you explain to me what the processes are of actually supporting the staff who are going to work in the community, how they are going to integrate in different working practices and ensuring the quality and safety care to the patients in the community? And there was a third little question, which I will sneak in, Chair, in regards to the existing patients that are resident in the hospital currently. What are the processes to actually safely discharge them into the community? Because I think I'm aware that there may be 4 patients. So there are 3 elements to the question. Diolch, Chair.
Diolch. Tracy, hang on to those, okay? I'm going to find out if there's any other questions, because it may be that you would answer more than one. Winston, Chantal, did you want to come? So let's go to Winston first.
Yeah, so my question relates to the financial impact. So, because what we've had here is a budget.
Winston, pull it towards you.
I shall try to speak louder.
That's great.
That's great. Okay. So my question relates to the financial impact. So you've helpfully set out what the budget was and the overspend for Kilgaren Hospital. But that's just one side of it, because we're actually going to be developing a GP surgery, community pharmacy, district nursing, community nursing as well. So for the board to understand what the full financial impact could be, it'd be useful just to set out where we are now and where we go to and what that impact's going to be because as a board we need to know whether we're going to be investing, and I'm hoping it's an investment, or whether we're going to be just saving money, or what does that look like, I think. Also just in terms of that financial impact, it's not just the existing budget. We're talking about, you also made reference to the fact that the body store needs a lot of work and the maintenance of the hospital needs a lot of work as well. So it'd be useful just to give the board that, and you may not be able to do that today, but to give the board an implication as to what does that look like. Is it millions and millions of backlog maintenance that we need to invest in? And in doing so, I think that strengthens the case for the safety and the safety of patients and safety of staff working in current facilities.
Great, thank you. Chantal.
So my question was in relation to the end of, oops, sorry, I've lost my paper now, but end of life care. And in particular that I noted that there were 21 patients that had been given palliative care in Kilgaren Hospital. So if that wasn't around, where would these 21 patients, where would they go? Yeah,
Great, okay, helpful. Right, let's deal with those questions on this side of the table first, and then we'll come to these next. Tracy, we're not putting you on the spot. If you can answer those or add to them or some of them, that would be helpful.
Shall I jump in on the Kilgaren tender first? Is that okay with everybody? So we are out to tender for a partner for the Kilgaren project. The tender is in the closing phases and we'll be going through an evaluation of the returns of that. So that's in the process at the moment. I think it's important that there is no change in direction for the Kilgaren project. That's still a board-approved priority and a board process. I am the project director for that on behalf of the local authority and the health board. So I kind of working closely with members on that on both in both organisations, and we'll work with the tender partner when we secure one. So that process is happening. In terms of the Kilgaren model, that is an investment. It's been an investment that has been made through Welsh Government funding grant up to now, in terms of the project, in terms of working up the design, in terms of working up the process. That's been happening now for a number of years in terms of the process. Members may well remember that we had a partner in place and we had to readjust ourselves because the partner decided not to continue with us. But that now has, I say, gone back out to tender. We've got some planning issues on that with phosphate in the Tyvee, and that's going to play into our thinking, but that is contained and can be contained through the proper mechanisms. In terms of the backlog maintenance costs for Kilgaren Hospital, we have been spending significant amount, tens of thousands of pounds per year on Kilgaren, repairing parts of the roof, repairing parts of the driveway, parts of the fire system, etc., etc. So that's been done on an incremental basis and will need to be done further again. So we will, I can recall easily now here over £100,000 worth of backlog maintenance that we've done in the last 2 to 3 years, really. So there's a lot of work gone on there in terms of the costs. So hopefully that covers the question in terms of where we go. The model going forward, if we talk about the model that Tracy is going to take us through in a minute, we're going to take the clinical staffing model or the clinical staffing budget from Kilgaren and put it out in the community. There's no savings attached to that, but we will have efficiencies of stopping people getting into hospital, and we will see the flow of hospitals increase, especially in bronchiolitis. So at this point in time, without the Kilgaren model, there is no additional cost or anything. The Kilgaren model will come back to board, ready for the business case when it goes into Welsh Government. So that will come back through the process again in terms of its overall cost and process going forward.
Great. I mean, truthfully, I think it would give confidence to the community to know that that model, that Kilgaren was underway. I think it would be very helpful in these circumstances. So we need not to lose that as a really important kind of end game for us in terms of how we work. Thank you, Peter. Tracy.
Yeah, if I can remember all the questions, but I think one of the questions there was around, thank you, was around how staff would transition, I suppose, from acute to community. So there are workbooks which have been developed for staff, So they would be signed off as competent. They would be placed in as supernumerary into into the DN teams initially, as supernumerary for as long as they needed, really, with that support wrapped around them. We do have a practice professional development nurse who works closely right across the county with the development of training and anything that's required, and that's from band 3s right up to whatever is needed. So there is a really robust training and competency and support mechanism around community nursing. And I suppose we've had to develop that because of the reason that, they are working independently, they're not on awards, they are having to make clinical decisions, although there is support from, senior staff as well. But we need to make sure that any clinical decisions, any caregiving is, very, very safe. And we do put a lot of the governance around anything we do in community.
Thank you, Tracy. There was a question about palliative care and residents.
Yeah, well, I think obviously previously Kilgaren has been one of the places where a lot of patients would choose to come back to have the end-of-life care, palliative care. Unfortunately, over the last, I would say, 6 months, we haven't been able to provide that care simply because we don't have the staff available. We are working with one qualified nurse, more shifts, which is quite difficult. So that has really impacted on the care that we've been able to provide to our palliative patients, sadly. We do have a robust palliative care team, and all of our community nurses are very able to provide that care. But what we have also done is commissioned some beds within our care homes that the majority of our patients do want to stay at home and they can receive that care at home, and that's what we try to do. But there are those times where patients don't want to do that, and it's not appropriate for them to do that for whatever reason. So there is that support that we can offer those patients then that care within the home. But those initial beds are wrapped around by our senior nurses. So we have senior nurses from the health board that oversee those beds on a daily basis and work with the care home staff. So there is that alternative that we are able to provide. But as I say, sadly, over the last few months, we haven't really been able to provide that palliative element of care within Kilgaren Hospital, which is because of the staffing and the fragility of the service that we are providing.
Okay, thank you.
There was the issue about the 4 existing patients that are currently in Kilgaren, and as people around here know, one of the patients was featured in the BBC item yesterday. So what are the processes for managing those existing patients safely and adequately out into the community, and the timescales of that, please?
Yeah, and I think that is ongoing, and obviously there are MDTs on a weekly basis with regarding every single patient that's in the hospital, regardless of the situation that we're in today. And obviously there are plans for every patient, really. I can't discuss what those plans are, but they are very robust. And obviously we will work with our local authority colleagues or whatever other colleagues that we need to, dependent on the plan, obviously for a safe discharge. Because I think I'd like to add, I think it's any single patient would, whether we're in this position or not, discharge would have to be safe. So I think that wouldn't change, because that's what we do anyway. So there would be no additional changes to that. And the time scales would be dependent then on obviously the needs of that patient and where they needed to go and how safe that would be in the time scale.
Thank you, Tracy. Helpful. Let's go to Sam. I'm going to come to you, then Michael, and then I'm going to come to Anne.
Thank you, Chair. So just responding from CLICE, the Citizen Voice body, we've been involved in this process from the start. I just wanted to touch upon a couple of issues, Chair, if I may. Firstly, just going back to the previous board meeting, just on the engagement process, I think that whilst we felt that that 4-week period wasn't necessarily ideal, it is the minimum time period recommended by Welsh Government guidance. We looked at a kind of compromise model based on the pressures that were there, and we always tend to focus on quality over quantity anyway in public engagement. So we did generally feel that the public had the opportunity to have their say. What I think we would say is that we wouldn't want this to be a routine approach of using minimum recommended engagement processes. Having said all that, I think the engagement paper within the papers does capture those different views, concerns and issues raised by the public pretty well. In terms of the outcome and our own response, we have written to Health Board colleagues. I think our response is reasonably nuanced. We're not opposing this proposal, partly because we feel that managed change in response to staffing crisis is always better than keeping a service going on the verge of collapse and having to deal with very urgent change. It's not good for patients, it's not good for anyone. And I think we'd also note, as has already been covered, models such as the community model in South Ceredigion showing good results. However, we do think there are things for boards to take account of. We do think the board needs to seek assurance that the proposed model is safe and delivering high quality care compared to those established hospital ward settings. It's good to hear that's been referenced as an issue already by Tracy, but it is something that we think that there needs to be rigorous collection of public or patient experience in these new models. We also think there's a need to describe any new pathway that the public might be accessing so that they can understand it better and it doesn't just hit them in the face when they become a patient within that. So in the past, the Health Board has used Tylee Jones to take people through that process. We've even we've been in discussions as well with Peter. He is considering some kind of event maybe as well with the public just to have that further discussion about how it looks. So that's something that we would welcome too. So just wanted to highlight those issues to the board today. Okay, thank you very much. Before I'm conscious it's not a question, it's more about a statement of what you believe. I think you're absolutely right. I think we need to adopt best, not minimal practice in our engagement with communities. I think in this instance it was short, but we should aspire to run full length conversations in the future, Sam, not least because those conversations mature over a period of time. They do not mature over the course of a month. So we do need to ensure we adopt best practice, notwithstanding the business contingencies around it. I think you're right. I think as a board we need to be aware. So not just think we've consigned this to an outcome, but actually return to this regularly to make sure that it is delivering everything that we would want. And it is, you know, if we think this is the case. Absolutely, I think ensuring that the public are informed and aware and confident and comfortable with what will be there in its place and how they access that seems to me to be absolutely essential. Thank you very much. Michael.
Thank you, Chair. In actual fact, a number of the points have been well answered, particularly by Tracy and Peter, and also Sam's points are. I speak as the lawyer who 10 years ago challenged the closure of Cardigan Hospital. Okay, judicially reviewed this health board on that basis, but that was all about no consultation at all, actually. And so it's a similar facility, similar kind of issues were raised, and we kept to the South Ceredigion model. So while I was slightly, my issue was the paper before us, and these are papers which are publicly read and available. Still, it seemed to me to kind of give the idea that it was dependent all on the integrated care centre, whereas it's not, because that is, in the paper it talks about that's an aspiration, that's yet to be signed off. So my concern was what's happening on the ground, and I think that's where having my colleagues here has been very, very helpful. So credit to the board for arranging that. And also I would like to say, I looked at the engagement document, and I thought the engagement document was, I thought it was quite good in that it talked about beds at Tregaron rather than accelerating models. I thought that was good. And it says quite clearly, it's anticipated that by changing the model of care, the same staff will be able to look after up to 40 patients in their own homes. And that is nice and clear, I think. And that's what I like. And so just my question to Andrew or to somebody is, that is absolutely right. That's not dependent on the integrated care centre. That is what we are going to get as a result of this move into the community, which of course, in general, must be the right direction of travel.
Okay, I think quite good from a lawyer is very good from everybody else. so thank you for that, and I take the same reassurance from what Tracy said in terms of using Tregaron Hospital as a hub for some of that work. So I agree with you. Very good. Andrew, I will come back to you. I'll just go to Anne first, and then come back to you then.
Thank you. My name's Anne Murphy. I'm an independent board member for the trade unions. So it isn't specifically a question. This is feedback from the union staff who've been involved with the staff in Tregaron about this move. And it really identifies the concern of the senior staff about the safety and the staffing. They're unable to supply a safe and stable service at this time. As Tracy just reiterated, only one trained. That's unsafe. All of her efforts to recruit were implemented but unsuccessfully, utilising bank nurses to fill substantive roles, which you're doing quite a lot in Tregaron. And like you said, it's a last-minute call-out all the time. And unfortunately, because of the situation of the siting of Tregaron, it seems to be local bank who can attend, because people from Aberystwyth, it's a 40-mile round trip. From Carmarthen would be even work further, so it's very hard to staff it. Like I said, this is feedback from the unions now. And so the bank nurses living locally are getting quite a lot of shifts and doing extra work to try and support you. So basically what they've come back with is the duty of quality and safe care to patients isn't being achieved, and the duty of safe and care to staff is not being achieved either. And they strongly support you, Tracy, with this because they feel so unsafe.
Okay, we have a fundamental duty of care to our staff,
Yeah.
as indeed we do to
Our
our patients as well. And I think we sometimes forget that. Thank you, Anne, for reminding us. Yes, please, Andrew.
Yeah, just in response to Michael's question, I'm hoping it's quite straightforward and doesn't come over as too short, but yes, and the 40 patients is based on our learned experience from the similar model we've implemented in the south of Ceredigion. So we're as confident as we could be in what that will deliver for us and for the population.
Thank you. The thing I would remind the board of is that one of those design principles is that it's consistent with our strategic approach to what we want to happen. And you will all know that we are striving to move to the community and into primary care those services that conventionally would have been hospital based. And I think this is an example of where we are moving in that direction. It's a painful move. It's not without disappointment, and it's not without anxiety, and it's not without worry, but it demonstrates the fact we have to move our services to a place where actually people can receive them in their own home or within their communities. For our future as a health board, it's exactly what we need to do. It's not about having less responsibility. In many ways, it's more responsibility on us to deliver that service, but it is consistent with our aspiration to become much more of a primary care community service focused health board in the future, and I would offer that to you as we consider the position now. So can I ask whether as a board we Well, two things. First of all, that we support the acceleration of the Kilgaren model, which I think is really important. And I take what you've said, Michael. It's, you know, there is something in place here to make sure that we are repurposing Tregaron Hospital, but it is part of how we would want to work in the future. And I think we need to support that as an ongoing development and bring whatever energy we can as a board to accelerating that process. Can I ask that we endorse that? Okay, thank you. And then can I ask that we approve the application and the paper to close the beds at Tregaron Hospital? Okay, we'll take that as a decision made, as agreed.
Thank you, Chair.
Thank you. Not with any disregard for the people who will worry about that inside their community, but with a positive view that we can deliver better and better public value as a consequence of making this decision. Thank you. Okay, thank you, Tracy. Thank you, Peter. That's been enormously helpful. Okay, let's move to our next item in the service change, which is the proposed overnight closure of the minor injury unit at Prince Philip Hospital. Andrew, I'm going to hand to you, but I know we've got colleagues joining us for this conversation as well.
Yes, thank you, Chair. I'm pleased to say that I'm joined today for this item by Dr. John Morris, who's the clinical lead for the Prince Philip Hospital Minor Injury Unit, Dr. Robin Golsall, who's the hospital director for both Prince Philip Hospital and Glangwili Hospital currently, and Sarah Perry, who's the general manager for Prince Philip Hospital and Glangwili Hospital, and is also the acting county director for Carmarthenshire as well, so has quite a broad remit in terms of services in Carmarthenshire.
You're very welcome. Thank you for joining us today.
Okay, thank you, Chair. So this, again, I will assume that colleagues have read the paper and just follow the same process I've just followed in relation to the previous paper, say a few words and give opportunity to my colleagues to add anything they would wish to add, and then open up for the discussion. The paper presented today proposes the overnight closure of the minor injury unit in Prince Philip Hospital. It's presented to the board today in response to clinical concerns raised by staff in the service, to members of the executive team, the board, and to Health Inspectorate Wales. These concerns have centred around the safety of patients accessing the service, particularly overnight, and the impact of delivering that current service on the welfare of staff in the unit. The concerns focus around an increasing challenge we face in the service in providing medical cover for the unit overnight, and the clinical risk this leaves the MIU nursing workforce to manage in the absence of GPs being available to cover shifts. The minor injury unit, when it was established, was not intended to provide a service to patients classified as majors, but 35% of attendances to the service overnight has this increased level of clinical need, which really should be attending the emergency department in Glangwili. The presence of a GP in the service overnight has helped mitigate this risk since the model was established in 2016. And whilst our emergency nurse practitioners are incredibly skilled members of that clinical team in minor injuries, they are not trained to assess and treat those major patients. The number of patients that attend the unit overnight are small, relatively, an average of less than 9 or 10 a night. But it's unacceptable to continue to expose our nursing staff to the critical risk presented without the support of a doctor present. Despite the best efforts of the Health Board, we have been unable to recruit substantively to the vacant posts in the unit. We currently have just 2 substantive GPs that cover 7 nights per month each, and we rely heavily on ad hoc shifts being provided by other GPs and locums to fill that rota. Sadly, covering the overnight period is not attractive as a role or shift, and we've seen the number of shifts without medical cover available double over the course of the last 12 months. I'm grateful to the work of the clinical lead, John to look for alternative routes to attract and recruit staff to cover shifts in the unit. In doing so, he has attracted a number of GPs to work in the service, but none are really interested in working overnight, as they all have other roles to undertake too. They have, however, provided added resilience to some of the daytime cover arrangements that we've got in place. Through the course of 2024, we've seen 3 further GPs leave the service and stop providing overnight cover. The most recent of those left the service in August. As we approach winter, it's really important that we have a clinical model that is safe to deal with the increased levels of activity that we always see through the winter. Failure to take action that does this will, I fear, lead to more staff leaving the service, making potentially the daytime service fragile as well. Operationally, therefore, acting on the advice of our clinical staff and clinical lead, we feel we need to implement this overnight closed unit from 8 p.m. to 8 a.m. every day of the week, initially for a period of 6 months. We will continue through this time to continue to recruit to the service and identify staff to support the service in an effort to address the medical rota gaps. The 6-month overnight closure will also provide us with added resilience to the daytime hours and enable us to begin a discussion with the local population, stakeholders and staff on a new model that enable us to safely maintain all of the Prince Philip Hospital appropriate care within Prince Philip Hospital and Llanelli. There are opportunities with this to improve access, quality of care and improve outcomes from a co-designed service with our local population. In the service, the safety of patients and staff within the MIU is the primary issue, and we need to address that risk, which is why this change is proposed as an urgent change at this moment in time. If I could just allow John and Robin perhaps to add a few words, particularly around, I guess, some of those clinical safety issues.
Hi, my name is John, the clinical lead for Prince Philip Minor Injury Unit. I've been a part of the team since 2016, and I've been the clinical lead since 2022. I think it's fair to say that in that period of time, a lot has changed. So the landscape has evolved. We find ourselves managing much more complex patients on a regular basis. The main concern for the staff within the department is that of unwell children, surgical emergencies, and problems related to pregnancy. And as Andrew has already suggested, when there is a GP present in the department, then that does mitigate a number of the risks. However, our nursing staff are not adequately trained or experienced enough to deal with that particular cohort of patients, amongst others. And in the last 12 months in particular, it has become increasingly difficult to find appropriate cover overnight, despite a number of different things that we have tried to recruit. And it's a very regular occurrence now that I'm getting messages, emails, day texts that detail the risks that the nursing staff in particular feel that they're facing. I could go on and on and on, but the main concern that we have is that the risk to patient safety within the department because of lack of adequate cover. And I'm happy to answer any detailed questions about that.
Thank you, John. Robbie.
It's Robin Gosher, so Hospital Director for Prince Philip and Glengwili Hospital. Just adding to what John has said, the minor injury unit is not a safe place for an acutely unwell child, an acutely unwell pregnant woman, or an acute surgical abdomen. That's not a safe place because the clinicians within that, whether that be nursing staff or doctors, are not skilled to be able to give the ultimate treatment for those patients. For those particular subgroup, the ideal place for them to go is to Glengwili for them to have the optimal treatment. And that's been the case since 2016. And so the fact, even though when the GPs have been present overnight, they still have not got the full skill mix to be able to deal with those. And there's been a big public push with information around those patients not attending, yet they still do. So that adds to the risk. What we do know from 2016 when the A&E changed the minor injuries unit and the AMAU is actually, although that was a roller coaster of a ride and there was many people who feared within the clinically population that they would have to travel afar for their treatment. Actually, what we did evolve is a highly successful system where patients who present with adult medical emergencies, the things that can be potentially life-threatening, such as heart attacks or strokes or respiratory conditions, can actually be seen far more efficiently within the acute medical unit. They got better care, they got faster care, and that certainly helped in terms of outcomes. Unfortunately, a subgroup of those patients still come in through the minor injuries unit, so they're actually getting less good care if they come through that way, as opposed through the more traditional route via the ambulances.
So, Robbie, just clarify for me. So, the majority of people who attend MIU are self-referred.
Yes.
Whereas, obviously, if they are coming to the medical assessment unit, then they are often referred to their GP
or an ambulance.
Or an ambulance.
Yeah.
Okay.
So, even though the headline for this discussion is around the MIU closure overnight, actually, I look at this as an opportunity to optimise the model. Since 2016, we've evolved. This wasn't a model that could have been initiated directly at that time because the AMAU at that time, in terms of other ways in, AMAU at that time didn't have the skill mix that's evolved over the last 10 years to a very highly efficient unit, which can deal with, as I said, very sick adults. There's a resus unit there, for example. In order to mitigate against the closure overnight, what we're looking at is ensuring that those patients within the clinical population who still have those adult medical emergencies are able to access the AMAU in a way which doesn't overload the system. So it's not, for example, a walk-in, but redirection through WAST, through 111, to ensure that those patients who would be getting slightly suboptimal care will get it as good as patients who come directly. We are conscious as a group of clinicians that that has to be in place in order for us to safely do the closure overnight. By definition, minor injuries unit is what it is on the tin. It is a minor injury. So minor, by definition, also means it can wait and wait till the morning if potentially required. If you get this right, it should not have an impact on the EDs or inappropriate impact on the EDs in Morriston or in Glengwili, because they cannot afford for that to happen because of the pressures on both those units. However, if a patient does have an acute surgical problem, they should be in Glengwili because that's where the acute surgical team is. If they do have a very sick child, they should be under the paediatric team in Glengwili. They should not be coming into the minor injuries unit. So ultimately, the model that we're evolving should be better, despite the fact on the tin it looks like it's a reduced service of minor injuries overnight. The one thing I will also add is whatever changes we make don't just count for overnight, because it's an establishment of this being 24/7. So whatever we put in place with WAST and 111, for example, should happen so that no patient, well, ideally no patient, who comes in with an adult medical emergency comes in via MIU, and that should have the additive benefit of taking pressure off the nursing staff and the medical staff that's within that.
Okay. Thank you very much. Would you like to add anything?
I think it's just really agreeing with both what John and Robbie have said, and I think it's really the impact of not having a specialty team on site for those specialty patients. So, paediatric, surgical emergency, that's the real risk that the emergency nurse practitioners are citing, and they feel very vulnerable professionally and are concerned about their registration and how those patients are managed.
Thank you. Before I open it up for questions, Anne, I'm just interested whether there's been any TU response to some of the risks or to staff working at the MIU. Not from Prince Philip.
I've talked to the staff myself.
Yeah.
Sorry. Not from Prince Philip on the union side, but I've talked to them myself as an IM, and they were very much asking when it's going to close because of the safety.
Okay.
And I've got a question actually as well to go with it. And really, the question is, how many times have we closed it already in the last 6 months? And that's quick Facebook messages out. The PPH is closed. So it's a very reactive in the time. So I'd like to know how many times it's been closed in the last 6 months.
Okay.
Well, the department has not closed as such. It's been nurse-led overnight. So we haven't had any closures of the department, but that is when the nursing staff have flagged up that they feel like they're most vulnerable because they are managing whatever walks through the door, regardless of the Facebook messaging, etc. So they're on their own managing children, unwell surgical patients, etc. So we haven't actually closed, but we have been without a doctor a number of times in the last 12 months.
Okay, thank you, John. Sharon, and then well, let's see what Sharon says, and then we'll go to Chantal and Dan.
Thank you, Chair. I just wanted to reiterate what John has said, really, in terms of the nursing staff. They are very skilled, but they are skilled within a specific scope of practice, and therefore they cannot work outside that scope of practice, and hence why they have raised the concern with the NMC, our regulator, and why we need to be having, taking action to make sure that we mitigate the risks associated with that. The other thing I wanted to say was that we did have a quality impact assessment. We've had a couple of quality impact assessments come through, and that was approved on the 12th of August, and we did undertake a full equality impact assessment as well as part of the process, outlining the risks that are within the paper and the concerns around quality and safety and the professional regulation as well.
In terms of the equality impact assessment, was there detriment? Did you identify any detriment in that?
With the quality impact assessment process, it's designed according to the domains of quality, so they're safe, timely, efficient, equitable, and person-centred. And the equitable often has a positive and a negative impact at the same time. And in this scenario, we considered the impact it would have because of the requirement to travel. However, if the unit were operating within the defined standard operating procedure, a minor injury or minor illness would not need to be seen at that point in time and therefore could be managed the following day. So that's how that equality impact assessment was mitigated, really. So we had, it's been quite a thorough process, really, to make sure that we've been able to articulate the quality and safety risks associated with the way the unit is running currently.
Great, okay, thank you, Sharon. So we have Chantal, Dennis, Michael, and then Anna. Oh, and Sam wants to come in. Great, okay.
Thank you, Chair. I just wanted a point of clarification. Does the MIU stand on its own, or is it co-located with the emergency department and the medical assessment unit? Is it because I'm sure when I visited, I can't remember which hospital I visited, but one of them, they were all co-located, but I'm just trying to understand whether it stands on its own.
So the minor injury unit location is where the old ED department was. So there's no emergency department any longer in Prince Philip. We sit next door to our SDEC, and the AMAU, so the acute medical assessment unit, is down the corridor. I think, given how small Prince Philip is, it's probably not that far away, but in context, we're not next door to each other, basically.
Okay, thank you for that.
Thank you. So let's go to Delyth.
Diolch, Cadeirydd. It's a question really about communication for the public especially, and in an issue for a parent or a relative of an elderly individual who they deem should go to hospital, what is happening about the communication with our population, because they see Prince Philip as their hospital, as their location to go to for help. So I notice on the recommendation it does say about communication, but if you're a parent of a sick child, you initially go to somewhere where you think that you will be dealt with. So I really want to unpack the definition of minor injuries and the liaising with our GP colleagues and WAST in particular as well, as to the information that is given to parents or to relatives of individuals that need a level of care.
Right, before we answer that, let's gather a few more questions. Hold on to that, folks. So, Michael.
Thank you, Chair. Yes, 11 years ago, I acted for the good people of Llanelli, suing the health board about, so this is like my greatest hits, this is today, because then it was a A&E, and a result of the outcome was the model we got now. So I do understand the issues of the good people of Llanelli on this, having acted for them in this matter. So, but that was all about a strategic decision at the time. This is, as I see it, this is operational. Okay, this is an operational response to safety concerns and staff concerns. So this is, so what I would like to ask is, and it's a 6-month closure on safety ground, operational grounds. So during those 6 months, is it, the fact that closure, is it right or is it wrong that closure ultimately of the unit as it stands at the moment is not inevitable? That during those 6 months, all various options will be looked at and considered, and we will attempt to think outside the box in this kind of matter. And thirdly, we get on with it, because again, it would not serve people well if after 5.5 months there's a cliff edge approaching and nobody knows what's going on, and 6 months doesn't become 12 months, then 18 months, because and so there's not that kind of slippage. So I would ask, is that right, what I've just outlined there? Thank you.
Great, okay, so, and I think that's a worthy challenge, because I think we need to have some degree of assurance in there as to how we move forward. I'm going to come to Anna, and then I'm going to go to Sam.
Thanks, Chair. So I think the problem that we're trying to solve here is that patients are too unwell for the skill mix and the staffing that we have available. And that is true even when we have a GP on site, because majors shouldn't be there. But it's made even worse when a GP is not on site, because it leaves the nurse practitioners clearly very exposed. And the solution that we're offering up, at least in the next 6-month period, is to close it, to sort of remove access and shut down the problem by that course of action. I suppose what I'm curious about is, what alternatives have we got to stream patients differently so the right patients end up in the right place, including those people with minor injuries who could be seen in a nurse-led unit, or is there no precedent for a nurse-led MIU in any part of the country?
Good question. Okay, and then Sam, and then I'm going to ask you to address those questions we've had raised. Sam.
Thank you, Chair. It's just a couple of comments, if that's okay. I think as a patient representative body, we were just as disappointed as the town itself when we heard that this overnight closure was going to be proposed. And I guess people will feel that this is another removal of a service that they value, looking back over recent years. I think from our perspective, if Health Board colleagues feel that the service can't be operated safely at this time, we can't argue against that. We're not clinical experts or experts in the sort of technicalities of healthcare logistics. I guess what we would say is that if the eighth most populous town in Wales doesn't have a full emergency department, if a 24-hour GP-led MIU can't be reliably staffed, and I guess, you know, and Robbie has also started talking about this, but what is the future of urgent care for the town? Which I think brings me to the main point that we look forward to a full and really committed discussion with the public as soon as possible, to look at the various options so that they can highlight their needs and concerns around urgent care, and ensure that one area isn't being disadvantaged over another. And just to say that in the interim, we just to pick up the point that Delith has made, we've been talking with Health Board colleagues, and I think we're pleased to hear that comms and public information is being put together, because people do have to alter their script of how they access that care at a time where they're pretty stressed and feeling poorly. So that's just what we wanted to say from a life's perspective. Thank you.
Thank you, Sam. Very helpful. Andrew, did you want to?
If I start, and then there's probably a couple of things that I'll look to colleagues at the end of the table just to add to. But if I go into particularly some of the questions that Michael has posed and Anna's posed. So no, a nurse-led. There are examples of nurse-led units elsewhere in Wales. There was one in Leithport Talbot Hospital, for example, not a million miles away, and we've got those elsewhere in the health board as well. So that is a model that could be delivered. Our challenge at the moment is the way the service is utilised and accessed through the local population means when we've had to resort to it being nurse-led only, we've put that additional risk on the staff of that they're running the service overnight. So there's a bigger exercise and conversation to have with the local population around that. I agree with Michael's point. This is very much at the moment in the operational space of we've got an immediate challenge, an immediate risk. How do we best mitigate that risk in the short term? But as I said when I was presenting the paper, I do believe there is a real opportunity through conversation with the local population, stakeholders, our partners and our staff to develop a model that provides a really good quality, accessible urgent care service and acute medical service in Prince Philip for a long period of time and is sustainable. One of the benefits of Prince Philip Hospital is that in terms of our medical team, we actually have a very robust workforce, a good rota. We attract staff there, so there are opportunities there in itself to work through how we redesign the service model to maintain that activity within the hospital. I think as Robin identified, that model and the opportunity probably wasn't there 7 or 8 years ago to do something different to what we've done, but the way the service has matured since then gives rise for us to have another conversation about that. I also think that within some of the service models we've put in place and some of the steps we've taken around the establishment of our streaming hub, for example, in Eastgate, that opportunity to provide a different point of access to care and stream people to the most appropriate service, often with scheduled appointments rather than having to sit and wait for a long time, is a very real possibility from a new model. And then just on the commitment for the conversation and not wanting to get to 5.5 months down the line without a solution. I've discussed this with Lee as Director of Planning. We would be really keen to commence a steering group that oversees the development of this model with key stakeholders almost at the same time as we have to take the action to close overnight. So that would be the first week of November. We would look to establish a group to start that conversation and start the work to meaningfully develop a sustainable model for the future, with a view that we would come back to board in November with a more detailed plan on how we plan to run that process over the course of the 6 months to get us to a set of options.
Okay, thank you, Andrew. Before I come to the three of you, Lee, did you want to add anything to that?
I think Andrew's covered it really. I suppose just to underline the point that as Michael was suggesting, this is a operational temporary change for 6 months. So on that basis, no options are off the table. We haven't got a fixed view on what the long-term model needs to look like, because as Anna's suggesting, there are a number of possible ways of delivering the service, and we'd very much want to work with the key stakeholders in the town and surrounding areas and the staff to consider all those possibilities, and we can update board in the coming months on that.
Great, thank you.
So I'll take the first part of it from a kind of strategic side of things. A couple of things. One is the Neatham Talbot model is they close overnight. So even though it's a nurse-led model, that's during the daytime hours. They don't function overnight. So it's just important to clarify that. And I think it's also important to clarify, bearing in mind the comments that have been made, it's a closure overnight. It's not full closure of the MIU. So during the daytime hours, it'll become far more robust. Although on the outside, it may look like something's been taken away. Actually, I don't think that is the case. I think it's about looking at our model, maturing it, refining it to make it better than what it is. The outcome 6 months down the line may well be, actually, this model is the right model. Because if you've got patients going to the right part of the system, because Prince Philip is part of a bigger system, it has a hugely important role. It's a massive cog in the wheel of how we are. But its role is around acute medicine. It's around, at the moment, elective surgery. and breast surgery, for example. That's our role within the health board. The other hospitals will have their own role within the health board. And one of the strengths for Prince Philip is actually some of the services that had moved 20 or 30 years ago has allowed Prince Philip to act in a manner which has attracted people of extremely high quality to provide medicine, not only from an acute medical perspective, but actually health board wide with their specialisms. And it's about adapting and evolving to make something sustainable. This isn't about something being taken away, it's about making it better than what it is. And I honestly believe if we get this right, in 6 months' time, and we're coming back, it's actually this model is better than what it was, it's safer than what it was, it's far more sustainable than what it was. Patients who are attending minor injuries units with a very sick child should not be going there, full stop. The reason I say that is, for that sick child, wasting precious minutes or hours being in a place that is not safe. It may be the local hospital, doesn't mean to say it's the safest place to be. It isn't. They're better off in Morriston or in Glengwili, where where the child can be treated quickly and safely with much better outcomes. So, and that hasn't changed. That was back in 2016 was the case. So the pathways aren't actually changing to what had happened before in terms of the cohort of patients. They should be going to the appropriate place anyway, regardless of all of this. But what the closure overnight will allow is optimising patient care. We're all very driven for caring of the population of Llanelli. We're also extremely cognizant of the pressures on the Morriston and on Carmarthen, and we have to be as one part of the system. So anything that we evolve and develop actually is about being better. Standing still isn't always the best option. And sometimes situations which arise, which for whatever reason may be the case, in this particular case it's resources, may not always be the worst thing. It allows you to look at what you're doing and make it better than what we're doing. And I think there is scope for that. We've proven that in 2016, that just because we changed something doesn't mean to say it's worse. In fact, it was better and far better than what it was originally. So we're investing our time as a whole load of clinicians, John as clinical lead, and myself as hospital director, to ensure that the population is served well. And we will make sure that happens in whatever service development that we make. John,
colleagues, do you want to add anything to that?
It's just to pick up on Robbie's last point there about serving the population. Someone who grew up locally to Llanelli, and I've worked most of my career since 2007 in the Llanelli region, in the original A&E, and then most recently MIU. And the staff in the minor injury unit are desperate to provide a solid service for the people of Llanelli. Most are local, most have been in the department for a very long time. And this decision has been the hardest of my clinical career. So we don't want to let the people of Llanelli down, but we want them to have a safe and reliable service. So that's why we've come to the route that we have. So we will work hard over the next few months to get a service that suits the patients of Llanelli. That's what we want.
So I just want to, Roger wants to come in, but there's something else for me, which is about the fact that, and I think, Robbie, you partly referenced it, will this add more pressure to Morriston, which is already under pressure? So we don't really want to, what we don't want to do is find that we are adding pressure to a hospital environment that's already struggling significantly, and actually probably what we need to do is have some fairly meaningful and solid conversations with our colleagues at Swansea Bay University Local Health Board to make sure that's the case, and to mitigate any impact if we were to agree this decision.
I think the key element to ensure there is an impact on Morriston or Glengwili is ensuring that patients who should be managed within Llanelli in the current and the previous system are managed within Prince Philip. So those patients who present with acute medical problems, for example via WAST, sometimes they are conveyed to a hospital which isn't Prince Philip. Despite various discussions, I think it's really important as a health board that we have those frank discussions with WAST to ensure that those patients go to the right place, which is Prince Philip Hospital if you're a resident, because that creates its own problems once they're in a different environment. What we always set out in 2016 to deliver in Prince Philip won't change. So therefore, by definition, if the patient is in the right part of the system, whether that be in the Hywel Dda system, or if it happened to be Swansea Bay, then they should be in there anyway. I think where we're falling down as in NHS Wales is we've got patients all over in the wrong part of the system. So they shouldn't be getting any more patients than what they should be getting anyway. What we've got to work hard is making sure that those pathways are in place to mitigate against that.
Yeah.
But actually that may be a beneficial thing because those patients who currently are conveyed, for example, Glengwili, in a new system will come to Prince Philip as they should, for example, strokes. We know there's a number of strokes that go to Glengwili and who are stranded on the stroke ward. We know that the proportion of patients go to Morriston and that 3/4 of their A&E is medical patients, of which a small proportion are clinically residents, who have, for example, medical emergencies. Well, why are they there? They should be in Prince Philip. So that's the work that should have been ongoing anyway, but this gives us the platform to ensure that that it is better. And I'm sure the outcome of this, as much as the headlines will say, is this is going to be better because patients will be managed in the right place at the right time.
Okay, thank you. Rodri, and then I'm going to try and pull us together to think about our decision.
Okay, thank you. Firstly, I welcome the contributions today. I think it's making this discussion very informative on a very difficult issue. The extra pressures on Morriston and Glengwili, that's been touched on. The only one I just wanted to pick up on, because that's 6-month timeline. Am I right, Andrew, to understand what you said just now, that there will be an options paper, future service provision, perhaps coming to the next board in November? Is that what you... I just want to get clarity on that, yeah, because you touched on it. I just want to get clarity on what is happening.
No, I think the approach will be brought to the November board meeting, and then the options will be developed beyond that.
I think we need that clarity just to understand what Andrew did mean. Thanks.
Yes.
Yeah, no, the chair summarised where the intention would be in November, or I was to say the intention would be that we establish a group with key stakeholders to start working through the discussion of the model, agree the scope of the work, agree the terms of reference, all those kind of things, and start the discussion, and then bring a paper in November that sets out the process and approach to making sure we do properly engage and involve the population in, and stakeholders in co-designing the model over that period, so that we can generate a set of options that we can come back to board at a later date during this period.
Thanks for that clarity.
Great. My question is, the board feel that you've had sufficient information to be able to make a decision on this?
Diolch, Cadeirydd. It's just the issue about the communication with the public.
Yeah.
And I think that is really key for us to understand. We will have a member of Teulu Jones presenting potentially at a minor injuries unit in PPH tonight. So we need to really actively understand what messages we are going to give our public so that they understand what the definition of minor injuries is.
Very good. Yes, please.
Just to reassure that, sorry, excuse me, we are working on a comprehensive communication campaign that involves both communicating this decision, whatever the decision is today, so that stakeholders and our community are aware of what's decided and what will happen as of when, because very conscious that if we are proposing a change as of, I think it's 1st of November, then we've got time until then that we need people to access the service appropriately. There is a challenge, back to your point of earlier, around what do people do when they're in a point of need, and I'm afraid to say that even with the best will in the world, a great communications campaign may not hit or land when you are in that point of panic and you have a small child who is in desperate need. So we will look to ensure that we will communicate as much as we can the routes that people need to use and the service access points, recognising that we don't have a consistent model across our patch. So it needs to be very localised and it needs to be suitable for Llanelli. We have, over the months and years, and when we introduced the model itself, communicated directly to the community about how to access the service and what it is. But again, there's a misunderstanding around what a minor injuries unit is, because you go to the place of safety and help that you believe at that point of need. So we will continue over the coming months to work very closely with communities in Llanelli and target that information to the point of need. But again, building on the point that Andrew made around working with stakeholder group, any insight and support that we can gain from members of our community would be very much welcome. Equally, thinking about the engagement and that people will want to share their views, we will ensure that as soon as we can, we will have a page on Have Your Say that enables that open input into the health board around this is what the impact will be as a patient of the service, so that we can continue to hear those voices as well. So, yeah, we're on it.
Diolch, Comina. So on the basis that I think we've had enough information for us to make a decision, I'm going to propose that we endorse this decision to close the MIU for a 6-month period. So we won't see it as a permanent change, we'll see it as a 6-month period. But I would suggest there are a number of provisos that we need to introduce as part of our endorsement of this decision. That is that we first of all need to be having a fairly rigorous conversation with Swansea to understand the implications of this in terms of any pressure it might have to that health board. I think that's really important. Secondly, Michael's point, which is we don't want this to run on, so we want a fairly robust kind of plan for how we address this in the long term. And I'm driven, Robbie, by your view that we can make things better. We can make things better and add more public value inside this space if we do this properly. So I think, as a board, what we would want in November is to have a very clear view about how we will go around developing those options. And then I think at the heart of that process will be full engagement with the community. So it isn't our decision, it's a community decision. So we would want everybody involved in that process to be able to make that decision and decide how we progress into the future. Is there anything I've missed in this? Sam, is there anything that you raised where we could take a further step or precaution inside this space?
Thank you, Chair. I think we'll be looking to discuss that with colleagues as we go. I think the key thing is that public discussion when the time is right, and we'll also be keen to understand exactly the kind of communications that Delith and Alwena have been talking about. So nothing further from us at this point.
Fine, okay. Andrew, the thing I would say before you come back is this is being driven by a concern for safety. It's fundamentally about safety. It's about being able to provide. I am anxious and concerned from what you've said about the pressure on staff inside this environment to deal with conditions that they're not skilled or equipped to deal with. Now, that's partly about working differently with the wider public. So there's a kind of mutual education process taking place in here. But it does feel to me we cannot afford to take that risk in the short term. But we do need to work with the community so they understand your point, Delith, that this is going to happen, and also the point about pathways. So there's clarity on what people will do instead or how they will operate and once this service is suspended for this period of time.
Yes, it was just a point of clarity because I may have misheard slightly. So it was just to be really clear, given the importance of this, which is that we are agreeing to close the MIU overnight from 8 p.m. to 8 a.m. It's not a full closure of the MIU.
No.
We just need to be really clear on that.
No, absolutely. And for a 6-month period,
yeah,
whilst we develop an alternative, safer quality plan. Anna.
Can I make a final check around the timescale? So we're saying, excuse me, the paper says the 1st of November. Given those safety risks that have been outlined, why are the risks of remaining open till the 1st of November more tolerable than the risks of a more rapid change?
That's a good question. Well, I mean, I might be wrong, but I would argue that we have a duty to the public for them to understand this change that we will be making. And we need to work with them on that change. I think it's a balance we need to operate inside this space, and for the public to understand that. I think the public quite rightly will say, well, we don't think you should be closing it. So there's an argument for us to be made in terms of the quality and the safety of care over this period.
And just to add to that, I think there needs to be a timeline to allow the pathways to be finalised for those adult emergencies, medical emergencies, to make sure we can get seamlessly to the AMAU. Because if we don't get that right, so the neighbouring hospitals are going to go down. So I think we do need that time period, and those conversations are quite advanced. So we're almost there. So with that bit of time built in, keeps the risk of taking the whole system collapsing as higher. But as those conversations have completed, then when you get to the 1st November, they'll be much more balanced out. So I think if it was an immediate closure overnight, I think that will be extremely detrimental safety-wise. So we need that timeline to ensure it's as safe as possible.
Okay. Does that satisfy your... there is a tension there that we need to manage through, but I think you've explained that well. This is another example of a decision that's difficult for us to make. It is about... And we know that it will disappoint the community. And it's not to disregard how the community feels about this, but it is to prioritise the importance of clinical safety and care over this period. And we will come back, our assurance is, we will come back with a more optimised model in the future. Thank you very much. Great. I'm conscious of timescales, so I'm going to move forward.
We've got Lisa, Prem and Nick for the Bronglice item.
Great. Would you like to join us for our next item? This is our third item on proposed changes to service. This is in relation to Bronglice paediatric services. Andrew, I'm going to hand over to you to open up this item.
Yes, thank you, Chair. And I'm sorry I haven't stopped bringing the difficult issues to the board yet this morning. So this is another difficult, I know is a difficult issue for us. I'm joined to support the conversation by Dr. Prem Kumar, who is our Clinical Director for Women and Children's Services and Paediatrics, Lisa Humphries, who's the General Manager for Women and Children's Services, and Nick Davis, who's the Service Delivery Manager for Paediatrics. And so
You're very welcome.
And as per the last two items, I'll bring them in to help with the questions and add anything when I've just introduced the paper. So again, I will, as I have done so far, will assume that the paper has been read. And let's just start by saying, again, this paper is presented today as an urgent interim service change to the provision of inpatient paediatric beds at Bronglice Hospital for a period of 6 months from the beginning of November. Since early 2024, the service sustainability risk on Anne Harrod ward at Bronglice has increased significantly due to shortfalls in the availability of qualified paediatric nurses. These staffing risks increased further in October when 2 senior members of the nursing team commenced paternity leave. The absence of their expertise compromises clinical leadership and quality of care on the ward. Through 2024, we have rotated staff from the service in Glangwili up to Bronglice to help cover some of those workforce shortfalls. However, we now have a level of shortfall in the Glangwili service from October, that means this support will no longer be available and can't be relied on to support Bronglice. Just for clarity, Anne Harrod ward consists of a 4-bedded paediatric ambulatory care unit, 6 inpatient ward beds and 1 paediatric high dependency stabilisation space. The proposal here in the paper is to close the 6 inpatient beds and transfer any children that may require a length of stay longer than 24 hours in hospital to Kilgaren and Glangwili. In reality, as the medical staff will still remain on site and as we will have that paediatric ambulatory care unit, it's likely that any child that needs care for up to about 36 hours will remain in Bronglice Hospital. So we anticipate It's only the really sick children that will need to transfer to Glangwili, and the numbers of those are really very small. We're anticipating it'll be around 4 children per month that may need to be transferred to Glangwili Hospital based on our assessment of activity and demand on the service. It's important to stress that that service remains 24/7, and it's also important to stress that the point of access for parents and the local population does not change as a result of that change. I am really grateful for the leadership of the clinical director and the clinical team and the directorate team in working up a model that is safe and retains as much care as possible in Bronglais as is safely possible to do so. We are continuing all efforts to cover the nursing shortfalls at Bronglais, and if we get to a point over the course of the next 6 months where we are able to fill some of those gaps, we will look to restore the service as quickly as possible before the 6-month period proposed in the paper. I am conscious that changes such as this, and particularly because it relates to children and paediatric services, do raise concerns amongst our staff, our community, but I do believe the option we've got is the best we can identify in the urgent operational sense to mitigate the risk that we will have from the 1st of November. I'll invite probably Dr. Kumar to see if there's anything else he wants to add in terms of that.
Thank you very much. So I'm Prem. I work as a consultant, I think first time in UK in Bronglais, so it's very close to my heart. I'm very passionate about the children's services up there. Ideal world, yes, we want to carry on as we are, but I think that's not possible. We've tried that in the last 12 to 18 months to keep going, but we reached a point that it's very unsafe to carry on as we are. So that's one of the reasons, with that in mind, we engage with the wider clinical team to sort of come to agree to a model that keeps the service safe and provides that high quality care. So it's one of the reasons why we all agreed as a clinical team to go for the model 2 as an interim. As Andrew suggested, is if the circumstances changes with improved recruitment, then we're happy to look back and see how we can revert back to where we were. So that's the view of the entire team, to focus on the model sort of 2s. By experience, even the busiest of the times, which is the winter of last year, when we look at the data, most children go home within 1.6 days, which is less than 36 hours. Those who need any ongoing support do come to Glangwili. By that time, they're much stable, and there's more expertise in Glangwili, be it diabetic care, we got a bigger setup, oncology, the cardiac, they all come to Glangwili anyway. So it is that culture where if there's any further subspecialist interest, or input that's required, they do come to Glangwili. So that's not a big change to practice, as what we are doing, but this will give us more a planned approach to this. And that's the general consensus of the clinical team.
Thank you very much, Dr. Kumar. Colleagues, anything you would add?
Sorry, hi, I'm Lisa Humphrey. What I will say, this situation has been really live and dynamic, I would say, since January. The local team have worked tirelessly to mitigate the position that we have been in. We were predicting at that point 40 ad hoc overnight closures. Now, I just want to add, closing a service in Bronglais with the distance that it is away from Glangwili in an unplanned ad hoc way is really, really risky. So, I mean, we got to a position where we managed to mitigate that and only closed 9 times in that period. Now, even in July, the situation has changed, so it deteriorates significantly in October, where we would, without changing the model for a period of time, we would be facing unplanned ad hoc closures, which increases the risk even more. Now, the team, when we engaged with the local team, and they are very passionate about maintaining a 24/7 service, because at one point we were talking about 12-hour services in our internal discussions. Operating this model, we have utilised the data available to us, the acuity of the patients, the demand on the service, and it is deemed that even with the local team, however much anxiety that causes, that actually we would be able to provide care for the majority of children. The care for the majority of children would remain unchanged at Bronglais. It's only going to affect a very small amount of children by enacting this change, and it is only for a short period of time, because such as the dynamic changes there are, we know now, even in the last week, we have actually had some applications for nurses, and we have secured some overseas nurses as well, be it adult trained with paediatric experience, but we've accepted those too as a way of working differently. So there is some light, if you like, that would allow us to, as soon as they were appropriately trained and inducted, to perhaps not have this change to go on for a 6-month period. It may be shorter, but you know, the key messages that are for those children who are accessing emergency care, nothing changes. For the majority of children that just stay for 24 hours, nothing changes. And there will be flexibility within that model as well in that short period of time to retain children a little bit longer. The team more recently now are working, the local team, so that's the consultants and the nursing team, are starting to look at the path, how we make this operationalise this model then and make it safe by making sure that we have really robust pathways in place, along with that daily oversight that we would put in during that change from a clinical perspective and a leadership perspective, to make sure that the children are receiving the care in the right and appropriate place. So I just wanted to add that for a bit of reassurance and context.
Great. Nick, would you add anything?
Yeah, thank you. Just a little word about the system pressures that the Health Board will encounter when paediatrics is at risk. So those 9 occasions, many of them have coincided when Bronglais as a hospital is in escalation and A&E is particularly precarious. But there are additional impacts on the ambulance service, and our conversation with the ambulance service has been they would much rather operate with a notice of a planned disruption rather than an ad hoc closure. That significantly affects the safety that we can offer children by not having this plan. Given the likely shortfall, the absolute shortfalls that we're likely to see this winter. And just to put things into context, our specialist transfer services, these are the doctors and the medics that are completely trained in all aspects of transferring children, are based in Bristol. So we need to make sure that we can do all we can. This is why it's 24 hours, why we're retaining stabilisation, no change to the medical model. And as Lisa quite rightly said, we've got some moves already. After this paper's been submitted, we've got interest, which wasn't there at the time the paper was written. So it's dynamic, it's fluid, it'll change. I've got a quiet confidence we'll be able to pull this back before the 6 months. It's not an absolute assurance, but I think even 3 or 4 days ago, I wouldn't be saying that to you. So the position changes all the time, but the risk is dynamic. Constant conversations with LICE throughout the entire period. Sam will know that we've had very varying options on the table. The last message to give, the difference this time is the skill mix, and that will affect the children that come in and the quality and safety that can be provided. And just to mitigate that, I'm very grateful to the Bronglais Triumvirate team who agreed to support us with adult nurses from the Bronglais site to counter some of the gaps that we're seeing, which allows us to retain that 24-hour model. Very important messages, I think, to give out.
Very good. Can I ask, just in terms of, because obviously the service provided by the hospital covers Powys or West Powys and also Gwynedd, Southern Gwynedd as well. Yeah. Have we thought about the impact it might create in terms of children, poorly children, kind of travelling from those areas?
Yes, so with the local service managers, I've had conversations with them. Anything less than a 24-hour service would cause massive disruption, which would include a complete change in pathways, and that would impact ambulance service as well. So you'd be talking about 909 ambulances from Aberystwyth going to Shrewsbury as a potential, which takes away from the local population even more. We've also had conversation about whether they can support our staffing deficit with any other altered hybrid model, and they are in a similar position where they don't have surplus staff or they don't have enough staff to come and support. So we've had those open conversations, and we'll continue to do so. We actually operate across Powys with our consultants, so there's a quid pro quo arrangement, I suppose, but they, even on that basis, they're not in a position where they can mitigate this risk with us.
Great, okay, thank you. Colleagues, questions or observations? Sam and then Michael.
Thank you, Chair. I just wanted to, I think praise colleagues for, as Nick has said, they've been in regular dialogue with us over recent months on this issue with a dynamic picture in terms of their staffing, and I think that arriving at this model is a relief rather than what it could have been. And that's overall good news amongst another difficult service change. It remains a change. Hopefully it is temporary and things can return to normal as soon as possible. And again, we are speaking with Health Board colleagues about some of the mitigations that may be helpful if there are families who are frequent attenders, or have open access, whether there can be some targeted communication there in particular, but to maintain a 24-hour service, given what the team has gone through, I think that is quite an achievement, to be fair.
Great, thank you. That's very helpful and very reassuring. Michael and then Dennis.
Thank you, Chair. Yes, just to kind of reiterate what I said on the last item, that this is, my understanding, this is operational, that in terms of long-term situation, if there is, it might right itself, people have suggested that, but if that's not the case, that all options will be properly considered in a proper engagement process going forward, and again, not to be left to the last minute. But so really repeating what my issues were in respect of Prince Philip, that applies here as well. Thank you.
Well made. I mean, I think I worry sometimes about these 6-month kind of periods because history tells us and lends us the experience of knowing it doesn't always, that 6-month period is, people see it as a breathing space as opposed to a space for delivering the resolution. But I'm partly reassured, Nick, by your sense that we're well on the way to addressing the issue at the current time. So I think that would be, that gives me assurance, if not complete assurance. Dennis.
Diolch, Cadeirydd. You've asked the question I was going to ask about Powys and Betsy, and that has been rehearsed. But is there a wider issue about paediatric trained nurses that we need to really flag up nationally? Maybe Sharon might come in on this, because there is a different skill set within adults and paediatrics. So is this being issued or debated nationally, especially with Huey? And bearing in mind we have a partnership arrangement with Aberystwyth University now, so do we really need to really rethink the conversation about the workforce issues going forward? Because the other questions have been asked. So diolch.
Shall I pick that one up? Yeah, thank you. Diolch, Delyth.
Pull the microphone towards you, Sharon.
Sorry.
That's okay.
Lovely. Okay, so you know that we have a pre-reg programme running out of Aberystwyth University, just over 2 years now, and that's adult and mental health at the moment. There isn't a paediatric branch running, from Aberystwyth. We are having conversations with HAIW, but I guess there's an opportunity potentially before that with some of the recruitment that we're doing currently. As Lisa said, we've got 3 paediatric trained nurses who've expressed an interest, so we'll need to see whether we can convert that. But we've also got overseas recruitment, and some of the overseas nurses may have paediatric skill sets, so whilst they may not be registered in this country, 2 of them have, Lisa tells me, we may be able to look at developing an OSCE programme with a workforce team to see if we can if we can get to a registration via that route as well. We have also explored grow your own models as well with our current NNEBs and healthcare support workers. And whilst they don't want to take that opportunity at the moment, that doesn't mean that that's not an opportunity we can explore as we go forward as well. So, as you know, the success for us in Hywel Dda is if we live local and train local, then there's more sustainability there for us. So yeah, there's a lot of work going on in that space.
A good question, Delith, because I think there is something about the succession planning, professional succession planning inside this place, which we need to do. We need to do really across the board in a number of locations, and it's problematic if we're contingent upon what we think is happening in the labour market to run this service. We need to be a bit more proactive inside that space, I suspect, as I'm sure you are. Chantal.
Thank you, Chair. Just to, Swansea University does run a children's nursing programme, which forms part of your IMTP as well as Swansea Bay. So perhaps a conversation in terms of either increasing the number of commission places or some way of how we can look at that particular issue.
Or the grow your own pathway would be an option. Yeah.
Great. Okay, thank you. Right, before we make a decision, I'm just going to hand over to Jo.
Yep, so thank you, Chair. So I just sort of rounding up the 3 items in terms of governance that, as we discussed earlier, these 3 items are all on Directorate Risk Register scoring at extreme level. And I guess just reflecting on the governance, we would normally expect these to come through our Safety and Quality Committee to have a view, which would then enable some of the board conversations we've had today. So I think that's something I need to reflect on to support yourself, Chair. But as part of that, if you'd be supportive to add to the recommendation generally that these 3 items, because they are about quality and safety that we provide to our population of services, that we ask through Anna's committee, Chair, through the Quality and Safety Committee, that there is an oversight now following the board decisions of any quality and safety concerns that may arise from any of those 3 papers, if you're happy to support that, Chair, and if Anna's happy as the Chair of the committee.
Okay, so 2 things. First of all, can I assume from the board that you have received or heard enough information to be able to confidently support or endorse this decision? Great. Okay, let's register that we endorse this decision for this 6-month period with a view to restoring services as they would want them to be safely within that period if possible, or towards the end if not. So that's fine. My observation linked to what you've just said is that we've dealt with 3 contentious, challenging issues, all of which have been kind of driven by safety and quality issues. And I'm pleased in a way that we've had this conversation around the board, but I'm slightly anxious that we're not being massively strategic about these issues. This is a reactive approach to managing this, and that's not helpful for ourselves or communities that we work with on a regular basis. So I think your reference to the Quality and Safety Committee is a good one, but generally we need to get more strategic about these things and understand them well in advance of, because it must feel a bit like fait accompli to communities because we have no other choice because of the safety issues. Whereas I think if we'd had a conversation before that and run through it and help communities understand why we're making these decisions, it's just a better way of working with communities and understanding what we're trying to achieve and what communities need from us at the same time. So can I suggest that, Andrew, when we think about these issues in the future, I'm sure there will be more service changes we need to think about and make, that we try and operate these in a way that they are more strategic and we get some more long-term running into dealing with them.
Yeah, no, I welcome those comments, Chair, and I think what I think the 3 papers have identified today is the level of fragility, risk and complexity that a lot of the operational teams are managing on a daily basis, and actually our route to resolving those is to have a really strong and robust and strategy that enables us to move forward in a way that's the population can support and understand.
Great, thank you very much. Thank you, colleagues. I think we'll break for lunch now. It's approximately 13:08. If we can take it to 30 minutes, be back here at 20 to 2. That would be great. Thank you very much. for coming back so promptly. I realise we're a few minutes late in terms of the meeting's agenda, but I'm hoping we're going to catch up over the next 30 or 40 minutes. Thank you for your acuity and your attention this morning. I think that was really useful in relation to those 3 challenging items, but I think the critique you brought to it was very helpful. Can I take us to the last agenda item of this morning, which was property leases and changes to that arrangements? I'm just going to ask Lee to introduce the item.
Thank you, Chair. Yes, the paper is presented in line with our board standing orders, seeking board approval for the proposed amendments to 4 lease arrangements. I think the paper is pretty self-explanatory, so I won't go into the detail, but the 4 are Kilgaren, which is an amendment collaboration agreement, which obviously we touched on this morning. Greenhouse, which is a deferral of the adoption date. Dura Park, which is proposing the replacement of a single existing lease with 2 separate leases. Good, thank you. And finally, Solver Surgery, which is a new lease agreement required following the board decision in July, which again we touched on this morning. So I'm happy to take any questions on it.
Yes, please, Maynard.
It's just a question on the greenhouse one. The actual break point is tomorrow, or on the weekend.
Monday.
Just wondering how we're handling that.
Yeah, so subject to the board approval today, the documents will be signed and sealed and couriered up to Cardiff this afternoon, but it is subject to, obviously, your agreement.
Great, thank you. Thank you, Maynard. Any other questions? Is everybody happy for us to approve the signing of these? Great, okay, thank you very much. Thank you, Lee. Okay, let's move into our maintaining good governance section, in which we update on the work of our committees. Can I begin with the report of the Audit and Risk Assurance Committee? I'm going to ask Rodri to speak to this item as Chair.
Okay, thank you, Chair. Well, this is a report from the 13th of August 2024, and if you look at some of the points in the advise Audit and Risk Assurance Committee wishes to advise members of the board in regards to the Health Board's escalation status due to concerns around the achievement of financial targets via the 100-day cycle and the need for cash contingency plans. Concerns was raised around capacity, capability and governance. The committee undertook a detailed and lengthy discussion around the actions being taken in response to the targeted intervention. In relation to Audit Wales' review of the cost savings arrangements report and the Hywel Dda management response, the key findings of the report were that the Health Board did not meet its financial targets in 23-24 and its track record on delivering recurrent savings is poor. A number of recommendations, 10 in total, have been made and the Health Board has developed a management response. Regarding the nurse staffing levels, the report due to the need of the cognizant of the potential financial implications of service and staffing changes. In relation to progress on transforming urgent and emergency care, due to the committee's inability to take assurance from the report as presented and request for a further update to the next meeting. With regard to progress on discharge management, an update was received, including around the establishment of a discharge strategy group and development of a toolkit. Disappointment was expressed at the continued lack of consistency in arrangements across the 3 counties. And then if I just I'll take the rest as read, and I'll just go to the sharing of learning, which is at the bottom, the need to be cognizant of the potential financial implications of service and staffing changes, the need to identify realistic timescales for actions. Learning from capital projects must be shared across the Health Board. Therefore, Chair, do you want to go through the recommendation or?
It's up to you. Do you think we would?
Right, well, the board is asked to note the items the committee is advising them of and take assurance from the items that the committee is providing assurance on.
Are we happy, board, to note the items and take assurance? Yep.
Thank you.
Great, okay. Diolch, Rodri. Let's move to report of the Quality, Safety and Experience Committee. Anna.
Thank you, Chair. So the report it stands as it is, nothing to add or alter, but I would like to draw the board's attention to the alert item, and this is in relation to autistic spectrum disorder diagnostic services. And Andrew's touched on this earlier on, so I don't want to rerun that conversation. However, I do think it's important to note the number of times that this issue or versions of this issue have been discussed in a number of different board committees and in the board itself, and a recognition that local progress is tied up in a much bigger all-Wales strategic position with which there seems to be pretty limited progress. And so the committee wanted to ask the board to consider the need to seek an appropriate route for discussion with colleagues at a national level in order to enable that material change in outcomes. And just before I pause on that one, I think it's really important that the board recognises the adverse life outcomes experienced by neurodivergent people in education, in housing, in employment, in the criminal justice system, and so on. So while metrics may be being reviewed or even, I wouldn't say deprioritised, but not focused on in quite the same way at a national level, the issue is still the issue. And the consequences of those poor life outcomes will show up in our health services for many decades to come. So this is a really important issue, and I invite the board to consider what, if any, action it would like to take to raise this at a national level. Otherwise, happy to take questions. Thank you.
Thank you very much, Anna. So I think that's a good challenge. So that suggests to me we need to be facilitating or having a conversation at a systems-wide Wales level if we're going to resolve this issue. Thoughts, colleagues, on how we might do that or the best route for securing that? Yes, please, Donna.
Thinking about that, where do we stand with the RPB in the children's portion of the RPB? Because that would be on a regional basis and bringing in our local authority partners in regards to education. So I'd like to know if there is any leeway in actually using that as a regional basis to really push the agenda nationally as well.
I can come in. I mean, look, I think your points are really well made, Anna, and the concern over the impact of this, and it's not something that's been a problem for a few months. It's been a problem for some time. So it is a serious concern. I mean, Andrew may be able to give some feedback on the discussions that we've had with Welsh Government about support for the service, because we've been flagging this. It may be that as a result of this board discussion, we consider writing to Welsh Government with just outlining the concerns and the reasons for them. Yeah.
I think that would be a very good solution. I think if what we could do within that is highlight the fact that we need a kind of all Wales conversation or solution around it, so to bring our concerns to their attention, but follow that through. Ardiana.
Thank you, Chair, and thank you. We can add that the Regional Partnership Board Children and Young People Board, now formed, is going through the prioritisation and taking on the matters that as a multi-partnership, as a regional partnership, can be addressed and can be accelerated. And that is definitely one of the top priority issues, which we could also feed through the RPB chair into the Welsh Government for a national address.
Great, okay, thank you, very helpful.
Perhaps we'll have a discussion with the RPB chair as to how best to approach Welsh Government, because we could approach ourselves, or we could do it as a region, which might have more weight because it isn't just a healthcare issue. Yeah.
Great, okay, thank you for that. Can I ask that we note? Oh, Andrew.
Sorry, what I was going to mention was, I may have referred to it earlier, we have got, I know Liz Carroll in her role as Director of Mental Health and Learning Disability Services has a meeting next week with the National Director for Mental Health and Learning Disabilities. So I'll make sure that through that conversation we feed in the fact that we're really keen to understand what the national timeline and programme for developing the more strategic solution around this area of services, and try and get some feedback through that route as well, so we can go it a couple of ways.
Great, I think that would be very helpful. Okay, thank you for that. Thank you, Anna. Can we also, we need to approve the duty of candour and duty of candour report. Sharon, you're going to commit at this point.
Yeah, thank you, Chair. The purpose of the report is to share with the Board for approval the Health and Social Care Quality and Engagement Wales Act first annual report, and to demonstrate how we've met the two main duties under the Act, namely the duty of quality and the duty of candour, as you've just alluded to, between the timeframe of April 2023 and March of 2024. The full report is available in the appendix, and I appreciate you'll have had an opportunity to read that. Just to summarise very briefly, the report demonstrates our commitment to improving quality of services to meet the needs of our patients, and this is more than just meeting service standards, as we've discussed this morning. This is a system-wide way of working. The report also describes what is in place to ensure that we meet our obligations in relation to the duty of candour, and how often the duty has been triggered and what the themes are. And that's covered in more detail on page 5 of the report, and we'll pick it up in the AGM as well this afternoon. So just to note and to thank the service, really, because the report has been written with information from the service on how they've managed to improve quality of care for Hywel Dda residents. And it's important to note the report doesn't cover all what we do, but it provides examples of what we have done during the year.
Brilliant, okay, thank you very much. Are we happy to approve? Board? Yep, great, okay, let's approve. Great, okay. So we're moving on to our report of the Sustainable Resources Committee. Winston.
Yeah. Thank you, Chair. Yeah, the Sustainable Resources Committee met on the 27th of August, and before the board seminar we had on the 11th.
Winston, pull the microphone
even more closer, right?
You're
okay.
not easy hearing the benefit of your wisdom.
It's not got used to my dulcet tones, has it? Really? Yeah. So I met on 27th of August before the board seminar on the 11th of August. Oh, sorry, September. So very much some of the alerts and highlights partially covered. First, I'm just going to go through the alerts, pause a bit, and then the recommendations. So the first thing is we still remain concerned about the financial run rate identified in the finance report. Clearly things have improved quite a bit since in the reporting of the figures since earlier in this meeting, but we're concerned about the challenge to get to £64 million deficit. The key risks that we wanted to highlight was we still haven't got cash management support from Welsh Government, so we will need their support in order to be confident that cash will be available to pay all our staff and our services to the end of this financial year. So that's the first alert. Second bit was we were not had the right level of assurance in relation to the savings, recurrent savings position. We identified at the time of the meeting the mental health and disabilities, but there are other areas. I think we still have a concern there, but not as great a concern as we had at that time. Third area I just want to bring to the board's attention was in relation to the Pentra Owl developments. We received the business case, and whilst we have a commitment as an organisation to follow that through, there is a significant revenue cost implication to it. You'll see in the papers attached to my report what that figure is. It was at that point 681,000 per annum, and we were concerned about that. We did have quite a robust debate in the committee, but we felt our strategic commitment overridden at this point our financial commitment, but certainly wanted to bring it to the attention of the board. I'm going to pause there for any questions or any queries that people have.
Colleagues, any thoughts or questions around the alert items that Winston's just articulated? Yes, please, Chantal.
Thank you,
Then
Chair.
Danny.
I just wanted to, because I know that the paper in relation to Pentra Owl has come to a previous board meeting, public board meeting, and I seem to have a vague recollection that in terms of the rental agreement, that would go up after 2 years. So if it's already significantly costly now, I just wondered, you know, is it sustainable in the long term if the rental is going to go up, or is that something that I've kind of dreamt rather than something I remembered?
Chantal, let's answer your question once we get to the item.
Okay.
So I think that's a worthy question that we need to assure ourselves of. Okay, Delith.
Diolch, Cadeirydd. It's just in relation to the Pentra Owl issue. Sorry, can you hear me?
Yeah, just to help with the flow of the meeting, if we could, there is a separate paper on Pentra Owl, so I just wanted it. Yeah.
Just to remind members that we are trustees and there is a significant legacy donation from the JC Williams Trust Fund and the Llanelli Hydrotherapy Pool, which we will be discussing later on.
Yeah, yeah. Thank you. Thank you for reminding us. Any other thoughts on the alert items Winston's raised?
I should go to the recommendations then, shall I?
Yes, please, because I think, to be honest, Winston, I think we would have covered a number of those this morning.
Yes, we have.
So let's move on to the recommendations.
Yeah, so we want to recommend to the board the Welsh Government funding the Picton Terrace lease should be signed under the lease seen by the Chair and the Chief Executive. I think that's a movement of HQ to Picton Terrace. There's also attached to my paper a committee to approve the process toward the tender of provision of dental services for South Pembrokeshire and Carmarthen. And I think there's more detail a paper attached to that. Also, the committee scrutinised and recommended for onward approval the patient flow and electronic observations for business case. And you'll see that that full business case is included in the board papers if anyone wanted to have further scrutiny of that. And finally, we also looked at the Sustainable Resources Committee terms of reference. We very much align those terms of reference much more closely to targeted intervention and the Welsh Government group that looking at the financial position across all the Wales. So that's all I wish to do, just to for the board to know.
Okay, so in terms of approving those items, I think we'll take them individually.
Yes, Chair, if that's possible.
And then we'll run through them as we move forward. So the first item is the Welsh Government Picton Terrace agreement.
So the first one we've got, it's a procurement report.
Yeah.
Yeah, procurement report. Excuse me, I can't speak. Procurement report. I'm more than happy to speak to. Thank you, Chair. There are 4 items here that need approval: the dental services award, the outsourced radiology reporting, pre-approving the GMS contract for Nayland Johnston, and the data centre storage, Chair. The paper speaks for itself.
Colleagues, questions or observations? Are we happy to approve? Great, okay. Yeah. So can we turn to the EOBS, patient flow EOBS business case?
Great, thank you, Chair. This is a bid that has come through our normal digital process, and I bring it here, I guess, with my digital part of my portfolio in mind. If the board approve this will be an opportunity to embrace transformational change within the digital space, and I'm pleased to be joined by Anthony Tracy, who's the digital director, on working with me on it very closely, Peter Skitt, who I guess is here with your 6 goals hat on, and Robbie, really grateful to Robbie for staying on to support this business case coming through. If the board do approve this, and I'll hand over to the team to present the case shortly, if the board do approve this, there is a challenge for us in affordability for the first couple of years. We have got 3 options there, so I'd be seeking board approval in principle today while we work through the 3 options. The first option would be to seek Welsh Government funding. That may be on an investor-save basis, it may be on a fully funded basis, and discussions are ongoing with Welsh Government to secure that. Secondly, if that fails, then there is the normal Health Board business planning process that we'll be going through, but that would necessarily delay then until next year any progress we could make. And thirdly, a digital transformation partner may be in a position to provide some kind of commercial arrangement which would allow the costs to be spread over the period with which the benefits could be realised. So we're working on what the funding option may be, recognising that we don't have our own funding being in deficit as we are as a health board. So with that, Chair, I may just ask Anthony to introduce and ask some comments from there.
Please.
Thank you, Chair. Just to check why this business case is here. It's been about 2 years in development. We've worked extensively with the operation team and also the clinical teams to pull together this business case. The outline business case was delivered to the board in March 2023 with a recommendation for us to go back out to the service and look at the quality and safety aspects and to get a little bit more on benefits realisation.
So Anthony, sorry to interrupt, really sorry. Can't hear you. Can you yeah, just speak into it.
Yeah.
Red light on it.
No, there's not a red light.
Can you press the button so there's a red light, please?
There's a red light now.
Can you want me to show that they are red lights? Thank you.
This is where technology gets me. So just to recap, this has been about 2 years in development for the business case. We've done extensive conversations with our clinical staff and also operational staff. One of the real good things about this business case is that this is the first time we've actually started with the business need, the business requirement, which was a patient flow system, an electronic handover system, and how we can develop internal referrals as well. And then we've gone through the people process, so the as-is processes across the health board to see how we can then provide a digital solution at the end. So normally we'd start with a digital solution and find a problem. We've actually started with the problem and found the digital solution, which is a real change for us in the digital remit. I think some of the problems outlined in the paper and also the business case are quite well documented. We've got many paper-based systems, many siloed, and we don't communicate across our acute community and also third sectors. And one of the premises of this system is to do that. This solution to do that. I think one of the key things before I hand over to Peter really is to reiterate the fact that this is a fully integrated system. So we are talking about hospital at home care. We are talking around a community and acute sector, and fundamentally overlaying this will be a command centre approach. So you'll be able to look at all of our patients across the health board and their state of care. The technical solution is such that we've already done the integration conversations with people like DHCW, and all of our e-observation systems, observation kit has actually been readiness. They are prepared and ready to actually link to the system as well. So that was one of the conversations we had. So I'll leave it there. There is extreme benefits outlined in the business case, page 35, I think, of the business case, and also in the paper. But I'll hand over to Peter and to Robin, and also take any questions after. So, Peter.
Thanks, Anthony. And we talked this morning, didn't we, about strategy and getting strategic and thinking things through. This process has been fantastic in terms of trying to work through what our new world looks like and our strategic direction and where we're at. And if we are to enable that to its fullest extent, we need a seamless system that enables us to do that. We talked about shifting care from acute into community. This has to happen. If it's going to happen, we need to have a seamless way of transferring people and moving people and referring people around the system to make that happen. So for me, the possibilities of starting the introduction of this system in the community means that we will fulfill our strategic direction. We will start to see more care in the community. We'll see more care coordinated in the community.
plus the fact, transitioning into my new role, I would also like to see this command and control centre in terms of a picture of the overall position across community and acute services from a care point of view. So this enables all of that and enables us to get a picture at any point in time of what's actually happening in the whole of our system, not just in those acute buildings that are, considered to be the centre of everything at the moment. We need a centre of everything that is overarching the community and the acute services, and this delivers that. I've worked in systems that have had these systems in before, and it gives great benefit in terms of patient flow, discharge, moving people through the system, and also in terms of clinical practice, linking people up and enabling referral between the clinical bodies. Over to you.
Thank you. I think if someone took a helicopter view of the health board, what they would see is the acute sector, primary care, and the third sector all completely fragmented. Even within the hospital setting, one hospital from one side of the hospital to the other side of the hospital, completely fragmented. So what you've got is something which is highly inefficient. And when something is highly inefficient, it naturally will affect patient care, and it ends up with money being lost or not used appropriately. The way things work is everything appears to be paper-based. What COVID has taught us is actually there's a new world out there, and it's time that as healthcare caught up with some of the other corporate businesses around technology and digital. If I could just spend 1 minute talking about a specific service which has gone completely digital, to give you an example. The lung cancer service for which I oversee, can't remember the last time I used pen and paper. We deliver the service, it's health board wide, from primary care through to secondary care across all 4 hospitals with multiple disciplines, and I don't use a pen and paper because everything is digital, to documentation within the portal so everyone can see in real time what the decision process is, to investigations being requested, to patients being informed of their journey of what's happening. That is one small part of what is the art of the possible. There is no doubt we have to move forward with digital to ensure that patient care is optimised, to make sure that even from consultants through to porters, everyone within the hospital, from primary care, who can refer in or get advice, or if a patient is discharged to hospital at home, that clinicians have confidence that those patients are on a journey of recovery, because some consultants aren't risk averse. They're worried about what's going to happen to that patient when they go out of the hospital doors into the ether. But actually, with a digital system where they can keep their eye on things, you'll start to see flow out of the hospital being much more robust and much quicker as well. The other thing, even though there is an outlay financially, if I was somebody who was working in England and I was attracted to come to the beautiful West Wales, what would put me off is going to a paper-based system, having worked within centres within England which are all digital. If we have a good digital system which shows the efficiencies, then you're going to attract people to want to come to Hywel Dda. If you attract people to come to Hywel Dda, you then don't have a resource problem. If you don't have a resource problem, you don't have a financial problem. We know one of the biggest sources of finances is having to pay for doctors and nurses because we are unable to fulfill the positions. So this is the future. We've got a choice here as a board and as a health board. We've got a choice. The choice is to live historically, and if we do, we're going to end up going down one road which isn't the right road, or we embrace the future and actually lead in Wales in terms of what we're able to deliver. And I think it's really exciting for what's been proposed. This is a really exciting opportunity.
Thank you, Robbie. And open to questions, Chair.
Great, okay. Maynard, do you have a thought?
I've seen this paper come through the various iterations. I was just reflecting back on what Robin was saying there. Once I joined the health service many years ago, and having an early conversation with a colleague, and he said one of the biggest problem in the NHS is patient flow. Nobody knows where the patients are, what they need, and what's going to happen to them next. And I think this starts to address that. It is a long-term project. It is using digital to transform the delivery of integrated care across the whole system.
Yeah.
I'd lend it my full support.
Okay, great. Andrew. And then
Thank-
Winston.
Sorry.
And then Jill.
Thank you. And I think Peter and Robbie have articulated really clearly and well some of the operational benefit and importance of the proposal that's before us today. I think the one thing I wanted to add, and just to emphasise, I think Robbie did touch on this quite well himself as well, but it was just the fact that one of the challenges or questions I've often gone back to Hugh with when we've looked at opportunities to improve performance or efficiency or productivity is when we're comparing with upper quartile and better performing organisations is, so what is it they're doing, what's the service model, what's the infrastructure they've got that we lack that would enable us to get there and to help shape the conversation. I think what I'm quite clear on is that in this space, most of the top performing organisations we look at, in fact I'd say all of them, we would look at to compare with in terms of operational delivery, will have had a system like this, at least for their acute services for some period of time. So for me, it's sort of just to emphasise, I think if we're really to realise our ambitions as an organisation, then this feels like a really intrinsic part of what the operational function will need to be able to deliver on that for the board.
Great, that's reassuring. Winston, then Jill.
Yeah, I just actually want to build on what Andrew said, because 2 weeks ago, I visited the occupational therapy department at Glenwood Willie Hospital, and invariably, one of their biggest issues was IT and the paperwork. That they were duplicating paperwork, they were taking notes on patients, inputting them into the acute hospital system, and then also having a separate system for community. And what they wanted to be able to have was just one patient care record that they could access and see wherever they were across Hywel Dda. So from their point of view, this, I think, would really enhance their work experience and their commitment to the health board. So that's really, really backed up what Andrew said. The other thing is that, absolutely right, Andrew, other parts of the NHS does have a seamless patient record system. We shouldn't underestimate what it will take to implement it. But for those laggards, we've got to really push ahead and say this is worth the effort, this is worth doing. I note that the benefits realisation aren't great in the first few years, but actually I think as you implement in different places, if it's almost like the good news will spread, and then people will just be working much more efficiently. If nothing else, saving in storage of papers all over the place, reduction in areas around care records getting lost. From a financial point of view, I have my concerns, but certainly from a strategic point of view, I've got no doubt I support it.
Very helpful. Jill.
Thank you. It's really just making sure we fully embrace the issue around community and primary care, I think, because we've historically stumbled through WICIS. We don't have any system really within the community around that. We've also got the advantage now of moving into a single system in general practice for the very first time, and I think that's a really good opportunity in terms of that interface. So, Peter, I noted you said that this could start in the community, and I think this is a really important part of the ongoing integration and delivery of our services. So thank you.
Thanks very much. I'm going to come to Phil, and then I've got a few observations myself. Oh, Robbie as well.
So it does seem really important, and I've been lobbied, I suppose, by lots of clinicians across the organisation. So I hear the need for it. Of course, it doesn't solve all of the digital issues we've got. We still need a electronic patient record. We need electronic prescribing, medicines administration. There's all sorts of components, but this is a really key component of it. And I suppose it, for me, if we start to become more strategic, as I think you mentioned, Robbie and Neil, how we are targeted in how we allocate our money towards digital and primary and community services is going to be really key to us going forwards. The thing that I think is going to be is tricky is, of course, the money and the funding of it. And we're health services are great at making investment, less good at the benefits realisation or identifying it. So we're going to need help from Hugh and colleagues as to how we really reap the benefits from it going forwards, rather than it just adding to our cost base, which would be very difficult for us given our financial situation. Having said that, when we're looking at this, there will be a myriad of benefits that will come from this, some that we can see, some that are, we wouldn't have even thought of.
Thank you, Phil. Rodri.
Yeah, just a couple of comments, regarding the return on investment, and is that a conservative figure? There's an annual cost, from my understanding, of 600,000, revenue cost on that, and just that last question then is, obviously we're talking about regional working and all that, are these compatible with, I'm just thinking, is it compatible with the health boards, and when it comes to regional working and perhaps ways of moving forward?
Okay, can I just ask a few questions, and then perhaps, so my questions are, as a software application, is it tried and tested? So this isn't something that somebody's trying to sell us, but it's been used and tested in lots of places. It's a vanilla product, I'm presuming, so it is as it is, as it comes in. So I'm often a bit worried about positive bias in the process, all the fantastic benefits of it, and usually there's kind of some negative consequences, or the challenges of introducing it can be more challenging than what we seem on the surface. I'm also thinking about whether it's been future-proofed. So this is something that in the future will take us forward. I think that's probably it. Having said all those things, I'm highly supportive of this, but I check my interest in this process, because I know my experience of having been involved in these programmes across government is that the devil is in the detail.
Chair, if I may ask Anthony to contribute to the tried and tested, vanilla and future-proofing, but if I just give some reflections on Phil's comments and yours around realising benefits. Absolutely, I think some of the challenge for us is going to be, it's not so much the system, the technical response, it's going to be the change management process that we need to follow to really maximise the impact that we're having across the system. This could be an enabler for huge transformation across and making our system integrated. And I think that's probably the innovative part of this, would be that this would be an integrated system across a whole system. I'm not sure that's been tried and tested hugely elsewhere, but this has been certainly seen in pockets in acute trusts on their own. We're just expanding the margins of that. In terms of positive bias, that's something I always check against myself, because there is always a risk of that. This is probably the first digital business case I've seen where the margins are so significant as to diminish the impact of any positive bias we might have in that. So it's not a marginal payback, it's a very significant payback. There is just that short-term affordability issue while we roll out in the first instance. But economically, over the life of this arrangement, I'm confident that it will give us the productivity gains that we need across the system. The challenge for us then will be to see whether those productivity gains can then be translated into cashable gains. But we need to start with delivering the productivity gains in the first instance.
Yeah, thank you, Chair. In terms of your questions around vanilla and tried and tested, this isn't implemented in Wales as it stands at the moment. We will be the first to implement this particular product. There are patient flow systems in some of the hospitals in pockets. In terms of the company's approach across NHS England, they are in upwards of 50 trusts in NHS England, but predominantly they are an Australian-based company and have significant presence in Australia. So they've tried and tested throughout the acute and community sector in Australia. In terms of future-proofing, this is, as Phil rightly pointed out there, this is our start of an electronic health record. We've already had conversations with the supplier and also our supplier of EPMA, and they have a very close working relationship. In fact, they've already integrated in other organisations, so that is a benefit instantly. And in terms of the GP systems as well, they've also integrated with the incumbent GP system as well. So that was part of the conversations that we had with the suppliers. What integrations have they already had nationally and internationally? Yeah. And they came through with flying colours from that perspective. In terms of adoption, that's always going to be the biggest problem that we're going to face. When we held the clinical sessions, there was an overwhelming support that this was an easy system to use because the supplier came down, tested it with our clinicians, they had a play for it for the afternoon, and they felt it was an easy system to adopt. So hopefully that allays some of the fears. Like I say, the future-proofing, that was one of the key elements that we looked at, simply because it will take a number of years to adopt and put into place, hence why, going back to Rodri's point around the benefits realisation and Winston's point, that we didn't instantly say from day one we're going to realise all the benefits. We know it's going to take us 18 months, 24 months to fully roll out, and therefore the benefits picture is the payback around year 3, year 4. So hopefully that allays some of the figures around the software. I do take your point around previous software installations that we've done nationally and also internationally that have come up short. I think the key to this is the way we started with the clinical voice, asking the clinicians, could you use it first, rather than digital come along and saying, here it is. I think we've learned some real big lessons as the digital team from the Welsh Nursing Care Record implementation, getting the clinical body on board, first of all, to say, could you use it? So that's kind of our approach going forward.
Okay, thank you very much. That's very helpful. Robbie.
Just one other thing to add from a patient's perspective. I think almost immediately within a system like this, they're going to have better care. It's going to be more efficient. There's going to be communication between clinicians, whichever background clinicians have come from. And it doesn't matter where they are in the health board. This takes out the postcode lottery, no matter where. So if I go back to lung cancer service, which is my main experience of it, is no matter where you are in the health board, you will get equitable service. You could be in the middle of Powys. You'll get the same care you will do from across the road in Connecticut, because it's all digital. And no matter how we work as clinicians and as clinical leaders within the organisation, we'll never truly work as one system if the digital doesn't follow it. We can try our best, and we will try our best, but if we truly want to be one integrated system within the health board, which benefits so many people, digital has to underlie that and underpin it. And that's why this is the most sensible thing for years, really, which has come around, and a package which can deliver so much is, I would say, it's my mind, a no-brainer, really. And as much as it's going to cost a lot, the benefits are more than just going to come out in 2 or 3 years' time. It's the clinical benefits are going to be much sooner than that.
Okay, great. Okay, fine. I mean, so I think we've probably heard lots of good argument for why we should be investing in this and why it's going to accelerate our kind of digital capability inside the organisation. I think there's lots of positive issues that sell this model to us as an organisation. I think the challenge is the financial challenge. So as you've described it, we can talk to Welsh Government about funding for this. I'm not sure whether that's something that they can support at the current time. This is not a great deal of money in the order of things. This is relatively small money. I know that sounds like an underestimation, but in terms of what organisations would generally pay for this kind of transformation, then this is a relatively low cost for a high impact outcome.
Chair, in terms of affordability, that's the process we're working through. So what we're seeking today is approval in principle, so I can go and work through either funding from Welsh Government and if that's not forthcoming, because there are clearly challenges and oversubscription on the digital demands from Welsh Government, a discussion with a digital partner about spreading the cost over the duration of the contract, and then failing those two, we would need to consider bringing this back as part of the business planning cycle, which naturally will be challenging for us and will be in the mix with all of the investment demands that we have in a resource-constrained environment. That will be a challenging discussion, if
Great.
that is the case.
Okay, and I think that's helpful. I wonder whether, in conversations with Welsh Government, an approach that leads to mutual investment might be a helpful step forward on our part, because it's absolutely vital we move towards this. Can I ask whether the board are in agreement to support this in terms of the next stage of the process and agreeing a financial approach? Definitely. So approve the award of the contract to the preferred supplier, subject to the successful resolution of a funding model to address the investment required in the initial years until the savings begin to materialise as part of the lifetime of the investment, and delegate authority to myself and the chief executive to authorise approval of the contract following the resolution for funding model as described above. Everybody comfortable with that? Great, okay.
Yes. Just say, if we aren't able to resolve it, then of course you'll be bringing it back here as part of the business case process.
Exactly.
Yeah. So our next item is around Pentra Owl development. Lee, I think you're going to take us through this.
Thank you, Chair.
Thank you, colleagues.
Thank you, Chair. Yeah, and this is a complex development and paper, so I'll just step the board through it just so we can be clear on the key points. So I think everyone knows the Health Board, we've been working in partnership with Carmarthenshire County Council on the development since 2016, so it's long in the development. It is a multi-million pound regeneration development in one of our more deprived areas of Hywel Dda. In overall terms, it is anticipated to create over 1,800 jobs in the area over the lifetime of the project, plus bring wider economic benefits of over £200 million through phase one. Alongside that, of course, the ambition is to improve the health of the population, the services we provide on the facilities we provide them from. The Health Board, just to bring absolute clarity, the Health Board will operate out of two separate areas. The first is a clinical decisions unit, which will include a range of services such as therapies, audiology, lymphedema, sleep and ventilatory services, as well as the Health Board's research and development and TriTech functions. The clinical decision unit is the area that we would be leasing as a Health Board, and that's what's proposed within this paper. Originally, just to remind the board, we were envisaging using 4 floors for that. We had to reduce that down to 2 floors because of the escalating costs, which we've appraised board of previously. The second area is the hydrotherapy pool, which is separate to the clinical decisions unit within the leisure part of the building, and that will be operated by the County Council. We, however, will have access to it for us to provide hydrotherapy services from that facility Monday to Friday. So that is not part of our lease agreement with the council, and we do not anticipate paying any rent rates or service charges for that. I just want to make that clear, because that is a complexity within the plans. Generally, whilst this represents a significant transformational opportunity, which I think is aligned to a strategic direction, we have noted in previous board papers and committee updates that there is a revenue consequence for the Health Board, which obviously is significantly challenged for us. We have sought to mitigate these as best we can as the paper sets out. So just to summarise that, the full cost of the clinical decisions unit would be 579,000, inclusive of rent rates, etc. Through a reduction in leases in the Llanelli area, as set out on page 6, we can reduce that. Separate to that, there are then the staffing costs associated with the hydrotherapy pool, which has an additional cost of 199,000. So therefore, the net revenue impact is 714,000. What we have done, as is noted, is look at further opportunities to to mitigate those costs. So the two key areas we've looked at are around the hydrotherapy pool staff provision, which might mitigate the staffing costs, and secondly, the options to utilise space vacated to reduce our dependence on leased offices at Eastgate. So if we're able to pursue both those options, that would reduce the anticipated net cost of 429, just so everyone is clear on the figures. What I would add to that, though, very importantly, is the financial assessment in the paper refers only to the direct quantifiable costs that we're able to identify, and we're not attempting to set out any broader financial benefits that we could get from Pendrawl development, such as improving the health and well-being and demand on services associated with that, benefits of integration with partner agencies, and any research and development investment opportunities that might come as a result of working in a facility with partners within that. So, and we do anticipate that will of course bring some benefit. Finally, and I know there's quite a bit of information here, but finally the paper notes that the Commission and the Clinical Decisions Unit does require additional capital investment, which is subject to a bid to Welsh Government. There is also a similar but smaller capital requirement for the hydrotherapy pool, which is also part of that bid. Since the submission of the paper to board, we have received correspondence from Welsh Government that in their judgment, the capital bid that we've submitted with the Council doesn't meet the IRCF criteria. So we are in discussions with Welsh Government in relation to that and what an alternative route might be. We're also in discussions with the Council as to what alternative arrangements could look like. So on that basis, what I'm seeking today is board approval for the lease to be signed, subject to satisfactory resolution of the capital gaps, because obviously we wouldn't want to sign up to the lease without knowing that we could operate out of it. So just to conclude then, I think it's fair to say the revenue implications do present us with a challenge given everything we've discussed already today. But of course it is a much broader transformational development which is very much aligned to the ambitions of our strategy in promoting improving health of our population and the determinants of health. So I'm looking for board support for that today. Thank you.
Okay, thank you, Lee. Colleagues, reflections or thoughts?
Chair,
Yes, please.
I think if my recollection serves me well, it was the fact that when we were looking at Pendrawl at a previous board meeting, that the costs go up after a while. I just wondered whether that's been factored in terms of sustainability.
No, that's no. The cost, the rent we're paying won't go up over time.
Won't go up over a period
That's a fixed thing. Obviously, some of the costs, like utilities and rates, could increase as over time as cost changes. But we're not predicting a step change in the way you're describing there, Chantal.
Okay, thanks.
So there's fundamentally a revenue cost, a net revenue cost of around 440k, and then there's a capital cost which we are seeking Welsh Government to support us in.
Correct.
The thing I would quite like to see in relation to this is further work done as to that broader benefit. So it feels to me this is an important investment on our part because it's a collaborative approach. It's working with the local authority. This is indeed, I think, a really great development. It's taken a long time to reach this space, but it's a great development. I do think there's something for me about the fact that we can see this as just accommodation to move into and a hydrotherapy pool. Or we can see this as a hub for thinking in a much broader way around how we impact upon health within those communities. And I'd probably like, it's money that we need to spend but fully exploit in terms of the benefits that it delivers back to the health board. So my request would be that we explore more fully the potential benefit of that as part of signing this at this stage. Delyth.
Diolch, Cadeirydd. It's really to reiterate the point. in regards the funding for the hydrotherapy pool, that it is as a result of a legacy donation from the JC Williams Fund and the Llanelli Hydrotherapy Pool Fund as well, from citizens of Llanelli. And I really, really agree with your point about the health and well-being element, because that was very, very key in the drawing down of the funds from the JC Williams Fund, is to really, really enhance the health and well-being of the citizens of Llanelli. And if we were not to go ahead with this, there would be a legal challenge and we would have to return a very, very significant amount of money to both funds. And correct me if I'm wrong, Joe, as governance, in regards the Llanelli Hydrotherapy Fund, that would be even more difficult as well, because they have disbanded. So there is that issue about really looking at the health and well-being of the citizens of Llanelli.
Thank you, Dallas. Joe, did you want to respond to that? And then I'm going to come to Hugh.
Yeah, so absolutely, Dallas right, as our chair of the Charitable Funds Committee, if the money was to be returned, there would be significant legal understanding and disestablishing what's been arranged. So supportive of what you said, Dallas, it would be very challenging, and then the money would have to be returned.
Great, thank you. Hugh.
Thank you, Chair. And yes, support that comment as well in terms of the challenges that would give us and indeed the corporate trustee to work through. I guess in many ways the revenue consequences of this are challenging for us to be considering at this stage, when we've had discussions around the challenging financial position in its broader sense. But this does give us an opportunity for a strategic asset in Llanelli, an area where we do need to see investment. What we're seeing here is the results of decision making over a number of years, and this has been a long time in the making, and pre-COVID and in a very different world, but commitments have been made in good faith to the local authority to work through over that period. I really want to commend the work that Lee's done to minimise the cost implications to us as a health board, and now the opportunity is there for us to maximise the benefit and the impact we get from this investment, and that's what we would need to see now as part of the next planning round.
Great, okay. Okay, I'm going to... Sorry, did you want to come in?
Yeah, I need to say, first of all, it's a very generous donation for the hydrotherapy pool, so we need that in mind, because without that there would be no hydrotherapy pool. We have been working closely with the local authority over many years, with good relations, on the basis that it would improve the health and well-being of the local population. I think the business case, there's a detailed business case. We should probably go back and examine that. What are the broad health and well-being benefits in that business case, and share them with board members. I think also on Hugh's point that we've been in this process for quite a number of years now. I think there will be some learning that we need to extract from how we engage with partners. I think it would really help us if we asked probably Joe or colleagues to think of how we could extract that learning from this process.
Okay, so can I take from your response that we are happy to endorse and approve the lease to be signed under seal by the Chief Executive and myself, subject to those conditions that we've included? Yep, great, okay. So, Lee, would you just take us through Picton Terrace?
Thank you, Chair. I think this is a more straightforward item, but it is a key part of our estate rationalisation plans, and it is a revenue saving and supports our broader ambitions to decongest our acute hospital sites, Glangwili specifically, whilst also supporting our town centres, and probably most importantly, it will allow the co-location of many of our corporate functions, which we expect to bring quite a lot of benefit in the way that the teams work together. You'll note from the Welsh Government has asked that we make a material contribution to the fit-out costs, and the agreement we've come to with Welsh Government is that we split that 50-50. We anticipate that for us that will mean that we will that our contribution will be made up of the proceeds from the disposals of Pond Street and Penlan when that occurs, and then the balance through our DCP, which we're expecting will mean a pre-commitment of 110,000 out from our DCP per annum to commence from next financial year.
Okay, thank you. Are we happy to support that and endorse that? Yep. Okay.
Can I ask, Chair, before we leave the sustainable resources item, which is not featured on the agenda, there are the terms of reference for approval as well, which Winston kindly raised.
Is everybody happy to approve the revised terms of reference, which look considerable to me when I went through them? Unfortunately, you've raised the issue now, and I need to take you back to an item in there that caused me a little bit of concern. I could. So on 2.4, oh, actually it's 2.5. Originally, within the terms of reference, 2.5 was to scrutinise and provide oversight of financial and revenue consequences of capital investment planning, which I thought was a good reference.
Yep.
And I couldn't find that anywhere else.
So that's now transferred to Maynard's committee. So we split it because the capital sits with their stock. So you will now see in the
fine.
terms of
Okay,
reference there,
great.
Chair.
Okay, that's fine. I'm comfortable with that. It's just that I felt it was a
we
useful
haven't lost it, Chair. Yeah.
Great. Okay. Thank you. So let's endorse those terms of reference. Right, Maynard, I'm looking at you to report on the Strategic Development and Operational Delivery Committee.
The paper is as is. There's one alert to draw attention to. It's already been mentioned about confidence in meeting the 100-day cycles, but that's already been mentioned and discussed previously. So the only other thing to mention is the recommendation to accept the winter respiratory vaccination programme delivery plan, which is also attached.
Great. Okay, so let's take you raised as an alert the 100-day cycle for delivery, which I think we've partly covered off in some of the conversation we had earlier on this morning. Nevertheless, it's a matter for us to remain vigilant around, and not to dismiss. On the winter respiratory vaccination programme delivery plan, Adriana, anything you would like to say?
Thank you, Chair. The plan, as every year, this year did go through the SDOT, the Strategic Development and Organisation Delivery Committee, as Maynard mentioned. I would probably just highlight one, which is a significant change this year in terms of the eligible population groups to be vaccinated with influenza, so seasonal influenza and COVID-19, and that is that this year, upon recommendation of the Joint Committee for Vaccination and Immunisation, the staff group, that is the health and social care group, will not be invited for vaccination, as it has been in the previous years, for COVID-19. Yes, for the seasonal influenza, but not for the COVID-19. However, we will make arrangement as a health board that should those staff groups or individual staff members require or request to be vaccinated, we have provisions in place for them to be vaccinated. Also to add that they will not be monitored by Welsh Government, so we will not be monitored on performance on vaccinating our health and social care staff for COVID-19. And that's the only sort of significant change in terms of the eligible population delivery. The rest of the plan is as we are in line with what the board approved early in the summer, the strategic plan for improving uptake and reducing inequalities in vaccination. We will have plans in place to try and do better this season than we have done in previous seasons, with focus on increasing access to 2- and 3-year-olds for seasonal influenza. Should those children not be vaccinated by their GPs, we will be going to the nurseries to offer the vaccination. Thank you.
Thank you, Adriana. SDODC has already approved this, so all we're doing is adding our approval to the process. Is board happy to approve?
The delivery plan. Great, okay. And obviously to note the work underway to mitigate the risk of the programme delivery. Thank you very much. Let's move to our next item, which is report of the People Organisational Development Committee. Chantal.
Thank you. And again, I'm making an assumption that everybody has read the paper, including the Strategic Equality Plan annual report. I wish to alert the board that the committee asked the board to identify which areas of inequality it wishes to include in its a list of priorities, as there are a number of issues within the health board, such as the gender pay gap. If you look at page 5 of the report, there's a list of issues around pay inequality, etc., that we would need to give some attention to. And the actual annual report itself is being submitted to the board for approval as a separate agenda item. And also wish to advise, although the committee took assurance on the identified controls and planned actions set out with the corporate risk assigned to the People's Committee, it is with the caveat that further work would need to take place as part and parcel of the risk 1821, which is the risk to the welfare of health board staff due to current demands. We already looked at the fact that there was a high percentage of people being off sick, and so we already looked at that. So the recommendations for today are for the board to respond to the items that they are being alerted to, for the board to note the items of the committee that the committee is advising them of, and for the board to be assured on the items that the committee is providing assurance on, and to approve the People's Committee terms of reference.
Colleagues, are you happy to support that? I have a comment under the Strategic Equality Plan, but I think I'll wait till that item. But it may relate to an urgent issue, which I can see in some of this information as well. Winston.
Yeah, sorry. Yeah, I also have a comment on the strategic equality plan as well. So a couple of things really. So ethnicity in recruitment and disability in recruitment. Where it shows that at the health board we need to look at this quite seriously. If you look at the proportion of people who are shortlisted or apply, shortlisted and get jobs, we have a difference. And you could make the argument that the health board is actively discriminating against those two groups. So we do need to. I don't think we should just leave it in People Committee. I think we need to address it as a whole health board, because, which often happens, if we have a reputation for this, then we won't be able to recruit the people we need to recruit in the future. So I think that was the one thing that, one of the things that really stood out for me in looking at this report. I think also the gender issues is a problem as well. I think actually when you look around the table, we're actually quite well represented at this level, but as soon as you go further down the organisation, we're not. And so we just need to make sure that managers are doing the right thing by way of our values and what we would expect them to do as a health board.
Right, okay, I want you to hold on to that comment, because I'm going to ask Lisa to just introduce the Strategic Equality Plan now, because your observation was exactly the same as my observation, and we do need to look at that a bit more closely. But in terms of Chantal's ask, in terms of the board here, I'm happy that we've noted the committees advising them of the issues that we're being advised of, and the alert item we'll pick up next when we discuss the Strategic Equality Plan. Great, okay. If we're comfortable with that, let's move to the Strategic Equality Plan annual report.
Okay, thank you very much. So the report that you have in front of you does highlight a number of areas where we have progressed within the organisation in terms of supporting our individuals, providing training, education, development. However, there are some things within that report that do highlight potential areas that we should be concerned about. So there are 4 areas in particular that I would like to just call out in the report. So one, as you have pointed out, Winston, is recruitment. So page 11 or 784, depending how you're accessing the paper, does call out the number of applicants that we have from individuals from Black, Asian, minority individuals, and there does seem to be a disproportionate number of individuals who progress from the application stage through to the offer stage for our Asian applicants and also those who identify themselves as black applicants. Very disproportionate when you look at the numbers compared to the white applicants, where the success of being appointed is significantly higher. We have been working with our senior management team in Prince Philip Hospital, who you will have met earlier today, who would like to work with us around how we look into this data, particularly for recruitment into Prince Philip. They too have noticed that the candidates that aren't progressing through. So our Equality, Diversity and Inclusion team will be working with the Prince Philip staff around the vacancies that we have on that site in particular to follow applicants through the whole process. We're also going to do some more ad hoc inputs into recruitment. So we're going to look at a vacancy from every single staff group and again monitor the application process all the way through to see what is happening in terms of those applicants. The second one that we have looked into is around career progression. So at the People Committee in August, we were celebrating the success of one of our internationally educated nurses who had received a promotion within 2 years of joining the health board. Having looked into promotion opportunities further, we discovered in the same period of time of 544 newly qualified nurses, 51 of those had been promoted to a band 6. So percentage-wise, a newly qualified nurse with no experience whatsoever had received a promotion, whereas an internationally educated nurse was coming to us as an experienced nurse. So again, we're doing some work with our colleagues, and you'll be meeting some of our internationally educated nurses later today to understand what is that about. Is it about our recruitment process? Is it about confidence to apply for jobs? Are we discouraging individuals? And therefore, what do we need to do to address that? The other thing that you will see in the report as well is that in pay bands 8B, 8D and 9, we have no racially minority staff. So it's just a real red flag, really, that not a single person in those pay bands. So again, we need to understand what that is about. Our OD team are looking at our leadership development programs, see what we can do to attract more people onto those programs. What more do we need to do, again, to support people and to attract individuals? In terms of that senior pay band as well, the other thing that you will notice in the report is that female to male ratios across the whole organisation, we are majority of female employees until you get to the senior pay bands where it starts to dip, and then when you get to a pay band 9, you then have more males than females. So again, first of all, why do we not have more males in those senior management pay bands? But when you actually get to the most senior of admin and clerical or agenda for change, why do we then have a flip with females? The new recruitment process that we have for all of our leadership roles at pay band 8C and above, we hope will mitigate some of the unconscious bias that could be in our recruitment process, because it adds a range of activities as part of the normal interview process, which could rule out some of that unconscious bias. So the OD team and the recruitment team will be working around that. The other thing that we are going to focus on as well is training. So again, you'll see a significant change in the numbers of people who are accessing training opportunities. We need to understand why that is. Are we collecting the data accurately? Why have we got such a massive switch? And then the final one that we wanted to focus on was around disability and recruitment. So of our 44,000 applications, only 3% were from individuals who declared that they had a disability. And of that 3%, so 1,300, 600 were shortlisted, with 183 being offered posts. So again, a significant drop in the number of individuals who are successful through the process. So again, that's a piece of work that our recruitment team are going to be focusing on to see what we can do to address that, and that will all be part of our action planning process that we'll continue to monitor through the People Committee. And I have asked that I'm going to be meeting with our 3 independent members around equality, Black, Asian minority and also Welsh language to see what we can do to set up a group that will start to focus in on this detail with our staff representatives as well to see how we can change the shape of the organisation.
Okay. Because of the availability of time, I'm proposing we do not discuss this at this time. This is worthy of a board development session. This data is astonishing, I have to say. I feel as if I've stepped back in an organisation 20 years ago. It feels, with a positive view, you might call it a cultural bias, an unconscious bias. With a less positive view, you would say it was racism. And that's not acceptable inside this organisation. But until we've got more information, we can't be clear or fully understand that. And we can't do that data justice in the course of the next 10 minutes. So I'm proposing we come back to a future board development session and look at the data in much more detail and work out as a board how we affect our leadership to make those changes inside the organisation. Because it's staggering, that data, staggering.
Totally support that.
Is everybody comfortable with that?
Yeah.
Shouldn't they? Great. Okay. Let's. And thank you, Lisa, to you and the team, because I thought the data was very good. So I think it's very good data. It's just it's worthy of a great deal of deeper analysis before we get to a good place on this.
Yeah. Thank you.
Okay. Great. So we will approve the plan, subject to the fact that we've got to dedicate ourselves as a board to looking at this in much more detail. Anne, I'm coming to you as report of the Health and Safety Committee.
Thank you very much. First of all, I'd like to thank Sharon Daniels, our interim nurse doctor. She was the executive lead in our Health and Safety Committee, which she's now left, and James has now replaced her. So he's become our lead in Health and Safety. So welcome, James. We've had our first meeting, and I'd like to say, since my other reports, this is going up now, okay? So we're getting happy. Because I've been coming to you the last 6 months with sad reports. So there's nothing adverse at this present time. The advice is, following the recent Health and Safety Governance Review, a plan is now in place to form a Health and Safety subcommittee to strengthen the reporting structures to the committee. The final references and subcommittee references were done, and this is going to come back to us in November. So we're going to start building a subcommittee to feed in and give us clearer reports. Despite the positive position with the report due to recent technical issues with the fire safety audit system, Boris, we couldn't take assurance, so we just took advice because there's some blips in the system, so they're clearing that out. The committee was unable to take assurance either from the manual handling organisation regulations, specifically in relation to people with higher body weight, due to lack of evidence to demonstrate the compliance with the operational regulations, and that's going to come back to us in January. The assurance we had was on the health and safety update, the fire management update, fire training, reinforced autoclave aerated concrete, and the defects cleaning agent. And the committee approved the health and safety policies. The review of the risks, the committee reviewed the corporate risks which are aligned to this committee. As part of its review, the committee considered the status of each risk and the current score of each risk. The committee noted the creation of 2 new risks, which is 1860, management of violence and aggression risk, and the risk 1861, the security management infrastructure and security management systems, which have been replaced from the single risk, which was 1328, which is now being closed. Due to the sensitivity nature of these risks, further discussion took place in committee, and we will be taking this discussion in committee here as well. So the recommendations, the board is asked to note the items the committee is advising them of, and the board is asked to be assured on the items that the committee is providing assurance on.
Great, thank you, Anne. Is everybody comfortable with that? Great, okay, thank you very much. Right, Joe.
Yeah, I'll be super quick, Chair. So this report covers the remaining committees that reporting to our board. So it covers our Mental Health Legislation Assurance Committee, our Remuneration Terms of Service, In-Committee Board, Staff Partnership Forum and Stakeholder Reference Group, and apologies, our Charitable Funds Committee. There's only some matters from the Charitable Funds Committee which are to be raised to the board, but we will need to move into trustee session directly after this meeting, Chair, to approve those as corporate trustees. So there's no other matters to raise to your attention.
Thank you very much. Okay, working in partnership. Bill.
So, yep, I have to take the report as read. I should point out that the because of the timing of committees again, there's since been a JCC meeting on the 17th of September where there's a more up-to-date information, but of course board members will receive that next time. We did have an update on the progress of the work which was called Recommendation 4 around the EMERTS review, which seems to be progressing well. That's the additional land-based service which should give enhanced access for the population of North Ceredigion. But otherwise, I'm happy to take any questions.
Okay, thank you very much. Great. Can we move to statutory partnerships update? Jill.
Yes, thank you. Nothing really to say in depth, just to say that the Regional Partnership Board is undergoing a review actually of its purpose and governance, and an external consultant is assisting in that process. I think it's quite timely, and I know that we are due as a board to have a little bit more of a look as to how this board works with the Regional Partnership Board and PSB, so hopefully that will inform the purpose going forward.
Thank you very much, Jill. Are we comfortable with that and note the actions? Great, okay. Let's move to any other business. Is there any other business? No? Great, okay. Let's move to, for information, you have a copy of the board annual work plan. That's just for information. Date and time of next meeting will be Thursday the 28th of November at 9:30. Location? Fine. Don't worry, it's not a major issue. Okay, because of shortness of time, I'm going to suggest we move straight into corporate trustee meeting. Welcome. No apologies, other than
just
the two.
Chair, just the Eleanor and Vice Chair.
Just Eleanor and Vice Chair. Can I check for any declarations of interest in relation to the items? We're approving? Great, okay, let's work from there. So, Sharon, I'm going to hand over to you. What we're going to do is ratify charitable fund requests over £100,000.
Thank you, Chair. I'll take the paper. Adele, if you might want to add a little bit at the end. So the board, in its role as corporate trustees of the charitable funds held by Hywel Dda, is requested to ratify the approval of 2 charitable fund expenditures requests that were considered by the Charitable Funds Committee on the 17th of September and have been recommended by the Charitable Funds Committee to the corporate trustees for approval within the scheme of delegation for the authorisation of charitable funds expenditure. So the first expenditure request is detailed in Annex 1, and it relates to the enhancements of to the outpatients areas in Bronglais General Hospital's chemotherapy day unit, which is above and beyond the scope of the current refurbishment scheme, in response to a legacy with a value of funding request of £115,779.40. Details relating to the scope of the funding are outlined in Annex 1. The expenditure of the additional 115,000 of charitable funds in this area would raise the standards of finish in the area to the same level as the main clinical treatment areas and create a seamless decorative environment at the unit. So this proposal was supported by members of the Bronglais Hospital Chemotherapy Day Unit Project Group at its meeting on the 18th of July. And just want to note really that the Hywel Dda Health Charities has not yet received the legacy gift from the donor, but the gift will only be made by the executors and accepted by Hywel Dda Charities following approval by the corporate trustees of the expenditure of the gifts for this particular purpose. So that's the first one. And then the second expenditure request detailed in Annex 2 relates to the purchase of 6 replacement Paxman scalp cooling units, plus a 5-year maintenance and training contract. Total value of charitable funds requested is £113,208. So the scalp cooling is an additional service which is above and beyond what is offered on the NHS. However, these devices offer patients an enhanced service and experience for those on certain chemotherapy treatments where hair loss or alopecia is a side effect. So the service is offered across cancer treatment centres in the UK. The units will be located at each of the acute hospital sites across the Health Board and are being replaced on the advice of clinical engineering. So that's a summary. Thank you, Chair. Yeah.
And to be fair, Sharon has really reiterated exactly what is in the paper. I think the first item is quite unusual, that I'd like to draw that to the notice of the trustees, in that the money will be released from the estate of the aforementioned will and the executors on our agreement to be removed. So it is not in the charitable funds bank balance at the moment, so it is subject to our approval that the funds will be released.
And it is conditional?
It is conditional on the refurbishment for the bronchitis chemo unit outpatients.
Great, okay, thank you for that. These have already been approved by the Charitable Funds Committee. What we're asked to do is to ratify or endorse that. Are we comfortable to do that? Yes, please, Hugh.
Just before we do that, just wanted to recognise and I guess send our thanks as a corporate trustee to the executors of the estate for a very generous gift to Bronglice.
Well noted. I think we should do that and formally write to them and thank them for that if that's not already done. Thank you very much. So let's ratify these appropriate spends. Great. Any other business? Winston.
Yeah, I've got one, and perhaps I should have mentioned this before, but in relation to our charitable funds, where do we invest? How much have we got, and what rate of return do we receive? Yeah, I mean, you can always answer that to me outside of this meeting, but I'm just aware that as a board, we've never actually seen that transparency.
There's lots of hands going up. I imagine that all takes place within the Charitable Funds Committee.
Absolutely.
But
and I would reiterate, it's a matter of public record under the Charities Commission. It is under our annual report. It is discussed at length at each Charitable Funds Committee, and we have a distinct financial report, and we are subject to a 6-monthly update from our charitable partner. Hugh, can you reiterate who they are off the top of my head? It's gone.
Chair, I've completely forgotten their name. CICA, I think. Or C something CA. But we will report back.
Thank you.
Winston, good questions, and it may be that a briefing offline will address some of those issues, so we can be certain on that.
And Chair, what we are doing for any IMs that have not done their trustee training lately, so your role as a trustee is separate to your role as a board member. There is a requirement that you do undertake that training where all of this is discussed as well. So that's coming up in the next month or so. So we'll make sure, Winston, you're on that as well.
Brilliant. Okay, thank you very much for that. Date and time of next meeting to be confirmed. Can I suggest we just take a 5-minute comfort break before we begin the AGM? Thank you very much. Oh.